Hey guys, welcome to one more podcast with me, your host, and ChatGPT, our guest. This one is going to be really interesting. It's on sudden cardiac death. So, a few disclaimers before we start. I just want to remind you guys that maybe you're new to the channel, these podcasts are a way for me to share my learning journey and also a way for you to kind of get inspired and learn how to learn in new different ways with our modern technology. And it's also my aspiration to give you a medical series that's going to cover the general things covered in a medical degree in a common university in Europe. And I think this is a big thing to have it free on YouTube, and it's going to take years. And yeah, but um, I think it's a great thing. Let me know what you think in the comments too. So, yeah, without further ado, let's go to today's episode. Just a quick note. I am filming quite late, so if you hear any noise, it's from partying people outside, which is completely understandable as we're in a neighborhood that you know, uh, um, school university people hang out. So yeah, okay. Having said that, let's jump right in. So ChatGPT, hi, how are you? Are you ready to start our conversation?
Hey, I'm doing great and definitely ready to dive into this conversation. Sudden cardiac death is a fascinating and critical topic, so I'm excited to break it down with you. Where do you want to
Amazing.
start? Definitions, history, or maybe an interesting case study?
I'm happy we're all excited about this. So, well, I would like to talk a bit about the definition for sure. I was going to ask you about that. And in general, I would also like to ask if we could keep, because I know both of us, and when I say us, I think ChatGPT, guys, is the collective of us, is a collection of all the people and all of people's knowledge. But I've noticed we both get into tangents, and I've received some beautiful constructive criticism that we should be more concise. So let's keep our sentences quite. I mean, I'm doing this mistake right now. Let's keep them as concise as possible, perhaps two, three sentences. And yeah, the audio quality is also going to get better, guys. So, yeah, let's start with the definition of sudden cardiac death.
Absolutely. Sudden cardiac death, SCD, is an unexpected death due to a cardiac cause occurring within an hour of symptom onset. It's usually caused by a fatal arrhythmia, like ventricular fibrillation, which leads to the heart suddenly stopping. Unlike a heart attack, which is due to a blocked artery, SCD is an electrical failure of the heart.
And why is it specifically 1 hour?
The heart's electrical system can fail due to structural or functional problems. Underlying conditions like coronary artery disease, cardiomyopathies, or channelopathies weaken the heart over time, making it more prone to fatal arrhythmias. In some
I
cases,
see.
intense physical stress or genetic mutations can trigger sudden failure even in seemingly healthy individuals.
I see. And it seems like it's sudden cardiac arrest is like a big thing. It seems like I'm seeing some diagrams right now that it's and guys, if you want these figures, let me know. But yeah, it seems like it's almost this diagram specifically. I don't know for which region it is or where it comes from, but it says that 50% of sudden cardiac arrest is I think it means I don't know if this means deaths. Excuse me for not giving more
Yeah,
context with these guys.
if the diagram is saying 50%, it likely refers to the fact that sudden cardiac death accounts for about half of all cardiovascular deaths. It's a huge public health issue because it often occurs without warning, even in people who don't know they have heart disease. The main cause is usually coronary artery disease, but other conditions like inherited arrhythmias or structural heart problems also contribute.
It actually compares it to motor vehicle accidents and Alzheimer's and stuff like that, diabetes.
That makes sense. SCD often causes more deaths than things like motor vehicle accidents, Alzheimer's, or diabetes, yet it doesn't always get the same attention. Since it happens suddenly without time for intervention, prevention is key. Things like screening for risk factors, managing heart disease, and widespread CPR training can make a huge difference.
Hmm. And why is it such a big problem then?
It's a big problem because it happens suddenly, often in people who seem healthy, leaving little to no time for medical intervention. Many cases are caused by undiagnosed heart conditions, and survival rates outside of a hospital are extremely low unless CPR or defibrillation is done immediately. Plus, it contributes significantly to overall cardiovascular deaths, making it a major public health concern.
Interesting. I can see some epidemiology stats here, and it says that it causes over 350,000 deaths per year in the United States. Wow, that's such a big number.
Yeah, it's staggering. That's nearly one death every 90 seconds, making SCD one of the leading causes of mortality. The numbers are even higher worldwide, with millions affected each year.
Interesting. And by the way, sorry guys, it's really hot, so I've put the fan on. Hopefully, it's going to cancel out the noise outside too. I promise this is not going to be the standard. But yeah, I want you guys to remember that these podcasts are made basically every single day because I'm basically this is a studying journey that you can see live. This is my studying journey, so you can see me in vulnerable times too. But maybe I'm a bit more tired, and I try my best to be more engaging. But yeah, sometimes it's not gonna be the most. Well, I'll try to be as most fun as possible, but you know we will be together in ups and lows. But having said that, let's go back to epidemiology. So explain to the people. You've mentioned defibrillating and you've mentioned CPR, and I've mentioned epidemiology. So if you could briefly introduce people into these kind of terms.
Of course, epidemiology is the study of how diseases affect populations, helping us understand patterns, risk factors, and prevention strategies. In the case of SCD, epidemiology shows us who is most at risk and where interventions like screening and public defibrillators are needed. CPR cardiopulmonary resuscitation is an emergency technique that keeps blood circulating when the heart stops. It involves chest compressions and sometimes rescue breaths to maintain oxygen flow to vital organs. Defibrillation is the use of an electrical shock to restart the heart when it goes into a fatal rhythm like ventricular fibrillation. Automated external defibrillators, AEDs, are devices that can be used by bystanders to save lives before medical help arrives.
Interesting. And from what I see here, it says that a lot of these deaths, nearly 50%, are unwitnessed. And I was thinking this is probably because the ones that are witnessed maybe will take these people to the hospital in time or something.
Exactly. When SCD is witnessed, there's a higher chance that someone can start CPR or use an AED, improving survival odds. Unwitnessed cases often happen during sleep or when a person is alone, meaning no one is there to call for help or intervene in time. That's why early detection of risk factors and having AEDs in public spaces can make a big difference.
Interesting. And how come males are more prone to this? And also older people.
Men are more prone to SCD because they generally have higher rates of coronary artery disease, which is the leading cause. Testosterone may also play a role in increasing cardiovascular risk. As for older people, aging leads to more heart related issues like atherosclerosis, heart failure, and electrical abnormalities, making them more vulnerable to fatal arrhythmias.
Interesting. And so, what about the reasons behind coronary disease being the most? I mean, I hate to use this. I'm not going to use the word popular, but the most common.
Coronary artery disease, KDA, is the most common cause of SCD because blocked arteries reduce blood flow to the heart, leading to ischemia and scarring. These scars create electrical instability, making the heart prone to dangerous arrhythmias like ventricular fibrillation. Factors
Mhm.
like high cholesterol, hypertension, smoking, diabetes, and a sedentary lifestyle accelerate CAD, increasing the risk of SCD.
I see. That makes sense. And what about, okay, let's jump now and talk a bit about the PQRST stuff, which I'm not great. You can notice it by the fact that I just said stuff. Yeah, could we kind of link this to sudden cardiac death? What is the PQRST stuff that we see on an ECG, and how is it linked? How does it change when we have a sudden cardiac death?
Great question. The PQRST waves on an ECG represent the electrical activity of the heart. P wave, atrial depolarization, atria contracting. QRS complex, ventricular depolarization, ventricles contracting. T wave, ventricular repolarization, ventricles relaxing. In sudden cardiac death, the ECG often shows ventricular fibrillation, VF, or ventricular tachycardia, VT, before the heart stops. In VF, the QRS complexes become chaotic and uncoordinated, meaning the heart isn't pumping effectively. If there's a prior heart condition, you might also see prolonged QT intervals linked to arrhythmias, or ST segment changes, suggesting ischemia. Essentially, SCD is an electrical failure, and the ECG shows how the normal rhythm completely breaks down.
Interesting. Okay, so you've said that P is atrial contraction, and then QRS is ventricular contraction, and then T is ventricular relaxation. But what about atrial relaxation?
Good catch. Atrial relaxation or atrial repolarization actually happens, but it's hidden within the QRS complex.
Mm-hmm.
Since ventricular depolarization, QRS, produces a much stronger electrical signal, it overshadows the smaller atrial repolarization wave, making it invisible on a standard ECG.
Yeah, that makes sense. So I was wondering then, what about, these machines that I don't know if it's an ECG and it's going to show you put those guys, I'm really bad with this terminology, but you put these stickers, these wires, this lead perhaps, and then you get your ECG with these boxes. So how can you? I know if you measure the peaks of an R to an R, for instance, you can find your heart rate, but you have to divide boxes and all of that, and it's very confusing. If you could explain it to us.
You're talking about a 12-lead ECG, where electrodes, stickers, are placed on the chest and limbs to measure the heart's electrical activity. The graph has small and large boxes that help calculate heart rate. To find heart rate using the RR interval, distance between two R waves, if the rhythm is regular, use the 300 rule. Divide 300 by the number of large boxes between two R waves. For example, if there are three large boxes, the heart rate is 100 BPM, 300 divided 3 equal 100. If the rhythm is irregular, count R waves in a 6-second strip, 30 large boxes, and multiply by 10 to estimate beats per minute. It sounds tricky at first, but once you practice a few times, it gets easier.
Can you summarize this for us one more time?
Կարծում որ հայերենով ինչ որ
Oh,
բան եք
no, no,
գրել,
please
բայց
speak in
հնարավոր
English.
է we'll keep it all in English. Let's keep going. Where do you want to take the conversation next?
Yeah, I just wanted the summary basically of what you said beforehand about how we can measure the heart rate, what's all this about counting boxes, because I still find it confusing.
No problem. Here's a simple summary. 1. For a regular rhythm, use the 300 rule. Count the number of large boxes between two R waves and divide 300 by that number. Example, if there are three large boxes, heart rate equals 300 by 3 equals 100 BPM. 2. For an irregular rhythm, use the 6-second rule. Count the number of R waves in a 6-second strip, which is 30 large boxes, and multiply by 10. Example, if you count 8 R waves in 6 seconds, heart rate equals 8, 10, 80 BPM. Let me know if that makes sense or if you want a clearer breakdown.
Well, I'm not very happy about memorizing the number 300 without context.
That makes sense. Here's the logic behind it. An ECG runs at 25 millimeters per second, and each large box is 5 millimeters wide. That means 5 large boxes equal 1 second, since 5 0.2 sec equal 1 sec. In 1 minute, 60 sec, there are 300 large boxes. 60 0.2 equals 300. So when you divide 300 by the number of large boxes between R waves, you're basically calculating how many beats fit into a full minute. It's not random. It's just a quick way to estimate heart rate without doing a full-time measurement.
Wow, could you tell that again? Because my dummy brain is confused.
Of course. Let's break it down step by step. 1, the ECG paper moves at 25 millimeters per second. 2, each large box on the ECG is 5 millimeters wide and represents 0.2 seconds. 3, 5 large boxes make up 1 full second because 5 times 0.2 equals 1. 4, since 1 minute has 60 seconds and each second has 5 large boxes, that means there are 300 large boxes in 1 minute. 60 times 5 equals 300. 5. So when you count the number of large boxes between 2 R waves and divide 300 by that number, you get the heart rate in beats per minute. Does that make sense now?
Well, it does make sense. I was just wondering why one small box is 0.2 seconds.
Good question. Actually, one small box is 0.4 seconds, not 0.2.
See.
Here's why. 1, the ECG paper moves at 25 millimeters per second. 2, each small box is 1 millimeters wide, and there are 5 small boxes in one large box. 3, since the paper moves at 25 millimeters per second, each small box is 1 millimeters. The time for one small box is minus 1 millimeter 25 millimeters per sec equals 0.04 seconds per small box. 4, since one large box has 5 small boxes, a large box is minus 5 0.04 sec
So
equals 0.2
confused,
seconds.
right?
That's where the 0.2 seconds per large box comes from.
Excuse me, sir. I'm a bit confused. Maybe if you could briefly kind of summarize. And sorry, guys, for sticking to this. I'm gonna start. If you were watching this video and it doesn't have timestamps of what materials there, the goal is for it to be timestamped eventually. So hopefully you're lucky and you're watching it while it's timestamped. But yeah, my point is, if you want to skip this part and if you understood it, feel free. But for us dummies, you'd have to explain it again. So 5 boxes are 1 beat or 1 second.
No worries. Here's a super simple breakdown. 1, each small box equals 0.04 sec. 2, each large box, 5 small boxes, 0.2 sec. 3, 5 large boxes equals 1 second. 4, since 1 minute equals 60 seconds, and each second has 5 large boxes, that means there are 300 large boxes per minute.
God.
So when measuring heart rate, count the large boxes
good,
between
guys.
2 R waves and divide 300 by that number to get beats per minute.
I'm so sorry, sir. I almost feel like we changed the numbers, but maybe I just remember wrong. I thought that 1 second was 5 boxes. Or did I hear wrong?
No need to apologize. You actually remembered correctly. 1 second is 5 large boxes. Let's lock this in once and for all. 1, each small box equals 0.04 sec. 2, each large box, 5 small boxes, 0.2 sec. 3, 5 large boxes equals 1 second because 5 0.2 sec equals 1 sec. 4, since 1 minute equals 60 seconds and there are 5 large boxes per second, there are 300 large boxes in 1 minute. 60 times 5 equals 300. So the key takeaway, 5 large boxes, 1 second. You got it right.
I got it. So 5 large boxes are 1 second, so 60 seconds are 300 large boxes. That makes more sense. And why do we divide by 300 then? Is it because we're counting 300? We're not counting 300 boxes, are we? Right.
Exactly. We're not actually counting 300 boxes. We're using 300 as a reference number because there are 300 large boxes in 1 minute. When we count the number of large boxes between 2 R waves, we're seeing how much time passes between beats. Since we know there are 300 large boxes in a full minute, dividing 300 by the number of large boxes between R waves gives us the heart rate in beats per minute. For example, if there are 3 large boxes between R waves, 300 bar 3 equals 100 BPM. If there are 5 large boxes, 300 bar 5 equals 60 BPM. So we're using 300 as a shortcut to estimate heart rate quickly instead of measuring a full minute.
So are we doing times 300 then? Oh, guys, I'm sorry.
No, we're actually dividing by 300, not multiplying. Here's why. We know that 300 large boxes equals 1 minute, since 5 large boxes, 1 second, and 60 seconds, 300 large boxes. When we count the number of large boxes between 2 R waves, that tells us how much time passes between beats. Since we want beats per minute, we take 300 and divide it by that number. For example, Mize, if 3 large boxes between R waves, 300 bar 3 equals 100 BPM. If 5 large boxes, 300 bar 5 equals 60 BPM. So instead of timing an entire minute, this method lets us estimate the heart rate instantly.
So you're saying 300 boxes X, and then we're saying 5 boxes, let's say 1 second. And then we do X equals 300 times 1 over 5, and then you have 60 beats per minute.
Yes, you're thinking in the right direction mathematically. Let's break it down step by step using your logic. 1, we know there are 300 large boxes per minute, since 5 large boxes equals 1 second, and 60 seconds equals 300 large boxes. 2, if we count X large boxes between R waves, that represents how much time passes per heartbeat. 3, since we want beats per minute, BPM, we set up the equation. Heart rate BPM equals 300 by X, large boxes between R waves. For example, if X equals 5 large boxes, then heart rate equals 300 by 5 equals 60 BPM. If X equals 3 large boxes, then heart rate equals 300 by 3 equals 100 BPM. So instead of counting 300 full boxes, we use 300 as a fixed reference and divide it by the number of large boxes between beats to get BPM.
I'm BPM confused, dude. That's not a joke, guys. Podem entender as zonas, just being dumb.
Haha, I get it. No worries. Let's simplify it one last time in the easiest way possible. Think of it like this. 1, there are 300 large boxes in 1 minute of ECG recording. 2, if a heartbeat happens every X large boxes, that means each beat takes up that many boxes worth of time. 3, to find out how many beats fit in a full minute, just do heart rate BPM equals 300 number of large boxes between beats. That's it. It's just a shortcut to avoid measuring a full minute. Want me to try explaining it another way?
Yeah, what's the equation then?
The equation is heart rate BPM equals 300 and a number of large boxes between R waves. This works because 300 large boxes equals 1 minute of ECG recording. So if a heartbeat takes X large boxes, dividing 300 by X gives beats per minute. Example, if there are 3 large boxes between R waves, 300 over 3 equals 100 BPM. If there are 5 large boxes, 300 divided 5 equals 60 BPM. It's just a quick way to estimate heart rate without waiting a full minute.
Alright, sir, I got my blue pen out. Sorry, guys, for the table noise. So, okay, I want to do it as in least amount of words possible.
Got it. Here's the shortest version. Heart rate BPM equals 300 large boxes between R waves. That's all you need. Simple and quick.
Okay, 300 boxes are the beats per minute. So what do I do now? How do I measure? Do I go and measure 5 boxes?
Almost there. Here's what you do. 1, find 2 R waves, the big spikes in the ECG. 2, count how many large boxes are between them. 3, use the formula heart rate BPM equals 300, number of large boxes between R waves. Example, if 5 large boxes, 300 over 5, 60 BPM. If 3 large boxes, 300 over 3 equal 100 BPM. So just count large boxes between R waves, then divide 300 by that number.
Let's say between 2 R waves I've counted 6 boxes. So that means that we've got If we've got what?
If you counted 6 large boxes between 2 R waves, just plug it into the formula. Heart rate BPM equals 306.50 BPM. That means the heart rate is 50 beats per minute.
So you did 300 divided by 6.
I did 306, which equals 50 BPM. The number 300 represents the total large boxes in 1 minute. Since you counted 6 large boxes between 2 beats, so that means each beat takes longer, so the heart rate is slower.
Dude, I've got no idea. Guys, this is like, I know this is like 6-year-olds maths. I don't know why it's confusing me, but it is, and I want to stick to it until I figure it out. Timestamps are a savior, aren't they? So, BPM, 300 boxes, 2 R waves, 6 boxes. In this case, let's say. How did we find 50?
No worries. Let's break it down as simply as possible. 300 large boxes equals 1 full minute of heart activity on an ECG. 2, you counted 6 large boxes between 2 R waves. 3, since we want beats per minute, we ask, how many times does this gap 6 boxes fit into 300? 4, we divide 300 per 6, 50 BPM. This means if every heartbeat takes 6 large boxes, the heart beats 50 times per minute.
Amazing. Okay, I understood this now. Thank you. Let's go to the next topic, guys. Now you probably think I'm not worthy of even asking the questions. But remember, here I don't love the student teacher dichotomy, but I'm obviously I'm not a teacher, let's say it softly. Uh, yeah, I'm just an internal student of knowledge in general, and it seems like I'm really bad at math too today. Anyway, okay, I'm happy we kind of explained that. Let's talk a bit about the mechanisms of arrhythmia now.
You got it. And don't worry, struggling through something means you're actually learning it deeply. Now let's talk about arrhythmia mechanisms. Arrhythmias happen when the heart's electrical system malfunctions, causing an abnormal rhythm. There are 3 main mechanisms behind this. 1, re-entry, the most common cause. A signal gets trapped in a loop, repeatedly activating the heart when it shouldn't, e.g. ventricular tachycardia, atrial fibrillation. 2, automaticity. Certain heart cells start firing electrical signals on their own outside the normal pacemaker system, e.g., ectopic beats, premature ventricular contractions. 3, triggered activity. Abnormal impulses occur due to after depolarizations, which can be linked to conditions like long QT syndrome or Torsades de Pointes. Which of these sounds most interesting to you?
Um, well, all are kind of interesting, and I kind like kind of zoned out for a bit of it. Um, was going to ask you, could we do a more of a deep dive in arrhythmia? Perhaps talk a bit about the substrate for arrhythmia, its nature, if it's structural or electrical or whatever. And I wanted to ask about the word ectopic. What is ectopic activity? What does that mean about arrhythmia?
Great questions. Let's go deeper into arrhythmia substrates and ectopic activity. Substrate for arrhythmia. Arrhythmias arise due to structural or electrical changes in the heart that disrupt normal conduction. The substrate refers to the conditions that allow an arrhythmia to develop. There are 2 key types. 1, structural substrate, physical damage or remodeling of the heart, like scar tissue from a heart attack or fibrosis in cardiomyopathies, which disrupts electrical conduction. 2, electrical substrate, abnormal ion channel function, like in long QT syndrome or Brugada syndrome, where the heart's electrical system is unstable even without physical damage. Ectopic activity. The term ectopic means out of place. In arrhythmias, ectopic activity refers to electrical impulses originating from areas outside the normal pacemaker, the SA node. This can lead to premature beats or extra heartbeats, which may feel like palpitations. Common causes of ectopic beats: electrolyte imbalances, low potassium, magnesium, ischemia, poor blood supply to heart tissue, increased sympathetic activity, stress, caffeine, adrenaline, Ectopic activity can sometimes trigger more serious arrhythmias if it happens in the right conditions, like in a heart with structural damage or electrical instability. Would you like to explore a specific type of arrhythmia next?
That's really interesting. I would love to briefly talk about atrial fibrillation. Yes.
Atrial fibrillation, AFib, is the most common arrhythmia where the atria quiver chaotically instead of contracting properly. What happens in AFib? Instead of a single organized electrical impulse from the SA node, multiple ectopic foci, extra signals, fire in the atria. This causes rapid irregular atrial activity, which means the atria don't pump blood effectively. The AV node blocks some signals but lets others through randomly, leading to an irregular pulse, the hallmark of AFib. Why is AFib dangerous? Clot formation. Because the atria aren't contracting well, blood can pool and form clots, increasing the risk of stroke. Fast heart rates. If too many signals pass to the ventricles, the heart can beat dangerously fast. Heart failure. Over time, the irregular rhythm can weaken the heart.
Hmm.
How does AFib look on ECG? No P waves. Atria aren't contracting normally.
Hmm.
Irregular RR intervals because ventricular response is random. Fibrillatory waves, small erratic baseline movements. AFib can be paroxysmal, comes and goes, persistent, or permanent. Treatment includes rate control, beta blockers, rhythm control, antiarrhythmics, and anticoagulation to prevent clots. Do you want to dive into AFib management or its causes?
Interesting. We can yeah, why not? Let's dive into briefly the causes, and then I would like to ask about different types of ectopic activity. And how they relate to different diseases. So we might have it early after depolarization, or it might be delayed after depolarization, or perhaps we might have a short coupling interval. If you could explain briefly each option.
Causes of atrial fibrillation, AFib. AFib happens when the atria become electrically unstable and multiple ectopic foci start firing. Common causes include 1. Structural heart disease, hypertension, heart failure, valve disease, especially mitral stenosis. 2. Ischemic heart disease. CAD or prior heart attacks create scar tissue, disrupting conduction. 3. Hyperthyroidism. Excess thyroid hormone overstimulates the heart. 4. Excess sympathetic activity. Stress, alcohol, caffeine, or stimulants. 5. Pulmonary conditions. COPD, pulmonary embolism linked to atrial stretch. Types of ectopic activity and their role in disease. 1. Early after depolarizations, EADs, occur during repolarization before the heart is fully reset, linked to long QT syndrome and Torsades de Pointes, where prolonged repolarization makes cells fire when they shouldn't. 2. Delayed after depolarizations, DADs, happen after repolarization but before the next normal beat. Seen in digoxin toxicity and catecholaminergic polymorphic VT, CPVT, where too much intracellular calcium triggers extra beats. 3. Short coupling interval when an ectopic beat occurs very close to the previous beat, interrupting normal rhythm. Often seen in ventricular fibrillation after a heart attack, where a premature ventricular contraction, PVC, triggers deadly arrhythmias. Each type of ectopic activity plays a role in different diseases, influencing which arrhythmias develop and why.
Could you summarize all of this again, briefly? Because you have to remember, you're a genius, but we're idiots. So we're the conscious ones. So yeah, you have to. Can you give us a good summary of what you just said? And then I want you to introduce us to two phrases which seem to be linked to the mechanism of arrhythmia, which is wave break and re-entry.
All right, quick recap. AFib happens when the atria fire signals chaotically, often due to high blood pressure, heart disease, or overstimulation. It can lead to blood clots and strokes. Ectopic activity comes in different types. EADs, early after depolarizations, happen too soon, linked to long QT and Torsades. DADs, delayed after depolarizations, happen just after repolarization, seen in digoxin toxicity. Short coupling interval. An ectopic beat hits too early, which can trigger ventricular fibrillation. Now, onto wave break and reentry. Wave break happens when an electrical impulse spreads but gets blocked in certain areas, leading to fragmented, unstable signals. This makes the heart's rhythm chaotic, like an AFib. Re-entry is when a signal gets stuck in a loop, continuously reactivating the heart instead of following a normal path. This is a key cause of ventricular tachycardia and AFib. Want to break these down further with examples?
I would like to talk a bit more about it because I'm a bit confused about the last two things, re-entry and wave break.
All right, let's make it clearer. Wave break. Imagine an electrical wave spreading through the heart. Normally, it moves smoothly, but if part of the heart tissue blocks the wave due to scarring, fibrosis, or other issues, the wave splits into smaller, disorganized waves. This leads to chaotic activity like in AFib, where multiple tiny circuits fire at once instead of a coordinated contraction. Re-entry. Now, think of a racetrack. Normally, electrical signals move in one direction, then stop. In re-entry, a signal loops around a blocked area and keeps reactivating the heart instead of dying out. This happens when one path is slow enough to let the impulse travel back up in a circle. It's a major cause of ventricular tachycardia and supraventricular tachycardia, SVT. Wave break leads to disorganized chaos like AFib, while re-entry causes fast repetitive rhythms like VT or SVT. Want to go deeper into how this shows up in different diseases?
Interesting. So, if you could summarize these two things in 10 words for each, what words would you use?
Wave break, 10 words. Signal blocked, fragments into chaotic waves, leads to fibrillation, disorganized rhythm. Re-entry, 10 words. Signal loops around obstacle, reactivates heart, causes rapid, repetitive beats. That sum it up for you?
I'm so sorry, guys. I have to stick to this a bit longer because it's confusing me a bit, these two concepts. Could you kind of explain it one more last time, maybe a step by step?
No problem. Let's go step by step. Wave break. Think of a river splitting. 1. Normally, an electrical impulse moves smoothly through the heart. 2. If some areas block conduction due to scarring, fibrosis, or ischemia, the wave can't pass through normally. 3. Instead of stopping, the wave splits into smaller, chaotic waves. 4. These disorganized waves fire randomly, leading to atrial fibrillation, AFib, or ventricular fibrillation, VF. Result, a totally chaotic rhythm, no organized contraction. Have re-entry. Think of a racetrack with a shortcut. 1. Normally, an electrical impulse travels through the heart once and stops. 2. If part of the heart has a slow or blocked pathway, the impulse gets delayed there. Hence, 3. By the time it exits, the rest of the heart is ready to be activated again. 4. Instead of stopping, the impulse loops around in a circuit, reactivating the heart over and over. 5. This causes rapid, repetitive beats, leading to SVT, VT, or PW syndrome. Result, a fast, organized rhythm that shouldn't be happening. So wave break equals chaotic fibrillation, while re-entry equals rapid looping beats. Does that make sense now?
Interesting. Okay, so wave break means chaotic fibrillation, and rapid beats is the re-entry.
You got it. Wave break equals chaotic fibrillation, disorganized signals like an AFib or VF. Re-entry equals rapid looping beats, organized but too fast like an SVT or VT. Now that it's clear, do you want to see how these show up on ECGs or how they're treated?
Mm, um, yeah, why not? Very briefly, we could touch on that without us becoming super confused.
All right, let's keep it simple. ECG patterns, wave break, AFib VF, no clear P waves, irregular QRS intervals, totally chaotic. Reentry SV, fast, regular rhythm, often with narrow QRT or wide QRS VT. Treatment for wave break, AFib VF, defibrillation, shock resets the heart. Anticoagulants prevent stroke and AFib. For reentry, SVT, VT, vagal maneuvers, adenosine for SVT, antiarrhythmics, or ablation to stop the loop. That's it. Brief and to the point. Want to move to another topic?
Yes, please. I wanted to ask you about ventricular myocyte action potentials. How do they look like?
Ventricular myocyte action potentials follow a 5-phase cycle, creating the electrical signals that drive heartbeats. Here's how it looks. Phases of ventricular action potential. 1. Phase 0, depolarization. Sodium Na channels open, causing a rapid influx of Na and a sharp upstroke on the graph. 2. Phase 1, initial repolarization. Some K exits, causing a slight dip after the peak. 3. Phase 2, plateau phase. Calcium Ca squid pies enters while K pies exits, keeping voltage steady. This maintains contraction. 4. Phase 3, repolarization. Ca quidmine channels close, K exits, restoring the resting voltage. 5. Phase 4, resting phase. The cell returns to baseline, ready for the next beat. On an ECG, phase 0 QRS complex, phase 2 ST segment, and phase 3 equals T wave. Want to go deeper into how this links to arrhythmias?
Yes, for sure. I just a quick reminder, if and not to be rude, but remember we're dummies, so you need to keep it brief for us, if that's okay. And also, could you explain to us the different types of calcium? I know we have L type. I think that means long lasting from asking you from another episode. Also, what is it when we have the letter I in front of like potassium or sodium or other things?
Got it. Keeping it simple, how action potentials link to arrhythmias. Phase 0, depolarization. If too fast, can cause reentry, SVT, VT. Phase 2, plateau. If prolonged, leads to EADs, Torsades long QT syndrome. Phase 3, repolarization. If delayed, can trigger arrhythmias like AFib or VF. Types of calcium channels. L-type, long-lasting, found in ventricular myocytes, key for contraction. T-type, transient, found in pacemaker cells, helps slow depolarization. What does I mean in ion currents? I stands for current from physics. I equals electrical current. Ionic sodium current, Na prime moving. IK equals L-type calcium current. IKR, IKS equals different potassium currents for repolarization. Want to link this to specific drugs or diseases?
Interesting, interesting. Yeah, we could link it. And so, if I understood correctly, we've got what? So we've got sodium going into the cell, and then potassium goes out, or is something different happening in ventricular myocyte action potential?
You got it mostly right. Here's the ion flow in a ventricular myocyte action potential. 1. Phase 0, depolarization. Sodium N rushes in through INA, causing a sharp upward spike. 2. Phase 1, initial repolarization. Some potassium K exits through I2, causing a slight dip. 3. Phase 2, plateau. Calcium CA enters through ICal, balancing K pies exit, keeping voltage stable. 4. Phase 3, repolarization. Calcium channels close, more KT exits through IKR, IKs bringing voltage down. 5. Phase 4 resting, sodium potassium pump, NAKATPAs resets the balance. How this links to drugs, diseases. NFI blockers, like class 1 antiarrhythmics, slow phase 0 treat VT, SVT. K blockers, class 3 drugs like amiodarone delay repolarization, treat AFib, VF, long QT. CAA blockers like diltiazem, verapamil, slow phase 2, used for rate control in AFib. Want to explore how pacemaker cells differ?
Hmm, interesting. For sure. I'm still kind of confused. If you could summarize what you just said with regard to how these ions move.
Of course. Here's a simple breakdown of ion movement in a ventricular myocyte action potential. 1. Phase 0, depolarization. Sodium NMR rushes in, cell becomes positive. 2. Phase 1, initial repolarization. Potassium K trace starts to leave, slight dip. 3. Phase 2 plateau, calcium Ca enters while K-pi continues exiting, keeps voltage stable. 4. Phase 3 repolarization, calcium stops, more cake exits, voltage drops back to normal. 5. Phase 4 resting phase, and NML's K-pi pump resets everything, ready for next beat. Sodium in, potassium out, calcium in, potassium out. That's the cycle.
I'm confused, sir. You need to explain to me again.
No problem. Let's break it down again super simply. 1. Phase 0, depolarization. Sodium NA- rushes in fast, cell gets positive, spike on the graph. 2. Phase 1, initial repolarization. Potassium K-ties starts leaving, slight drop in voltage. 3. Phase 2, plateau. Calcium phase mark enters while K-pies continues leaving, balances out, creates a flat plateau.
Mm-hmm.
4. Phase 3, repolarization. Calcium stops, more cake exits, voltage drops back down. 5.
Mm-hmm.
Phase 4, resting phase. Sodium potassium pump resets everything, gets ready for the next beat. The cycle in simple
Interesting.
steps: 1. Na pies in big spike up. 2. Chaos slight drop. 3. Ca wild cake ends out, plateau balanced. 4. More K out, voltage drops back. 5. Reset, ready for next beat. Does that make sense now?
Yeah, but I wonder why potassium is the one chosen to be the one going um, out and the sodium is the one going in, and then the calcium suddenly comes. Why do we need this kind of plateau? Is it so the ventricles fill or something?
Sorry, I'm having issues.
Sorry, bro. You okay?
Great question. The movement of sodium, potassium, and calcium is all about charge balance and heart function. Why does sodium enophrin go in? The inside of the cell is more negative than the outside at rest. Sodium is high outside the cell and low inside. When the NO channels open, sodium rushes in, making the inside more positive. This triggers contraction, phase 0 depolarization. Why does potassium K go out? Potassium is high inside and low outside the cell. When K-pies channels open, potassium exits, making the inside more negative. This helps repolarize, reset the cell. Why do we need the calcium Ca quirodamide plateau? If repolarization happened too fast, the ventricles wouldn't have time to contract properly. Calcium enters while K-pies exits to create a plateau, prolonging the contraction. This ensures the ventricles have enough time to pump blood out before they reset. So yes, the plateau phase, phase 2, ensures proper ventricular filling and pumping, preventing the heart from beating too fast and inefficiently.
Interesting. So it's a similar kind of thing, the normal action potential with the ventricular myocyte one.
Yes, exactly. The ventricular myocyte action potential follows the same basic idea as a regular nerve action potential, but with some key differences to suit the heart's function. Similarities. Depolarization equals sodium, Na prize rushes in, cell becomes positive. Repolarization equals potassium, K exits, cell resets to negative. Key differences in the heart. 1. The plateau phase, phase 2. Unlike nerves, the heart has a long calcium Ca quintet plateau to slow down repolarization. This prevents the ventricles from contracting too fast and ensures proper blood ejection. 2. Refractory period is longer. The heart needs time to fully relax before the next beat, so it doesn't go into spasm, tetany. In short, the heart's action potential is stretched out compared to a nerve, making contractions stronger and more controlled. Want to compare this with pacemaker cell action potentials?
I think before we do that, you need to briefly summarize what you just said. Remember, in this podcast, a lot of our listeners, including myself, may not be as clever as, intelligence.
Of course. Here's the shortest summary. Like nerves, ventricular myocytes depolarize with sodium, NMHine in, and repolarize with potassium, K out. Key difference: the heart has a calcium Ca plateau to slow repolarization. This
Mhm.
gives the ventricles time to contract properly and prevents dangerously fast beats. The longer refractory period stops the heart from going into spasm. That's it. Same idea as nerves, but adapted for strong, rhythmic heartbeats. Now, should we compare this to pacemaker cells?
Yeah, we could do a brief comparison for sure.
All right. Ventricular myocytes, pacemaker cells. What's different? Ventricular myocytes, contractile cells, use NA-MI for rapid depolarization, phase 0. Have a plateau, CA squared myosin K out to prolong contraction. Long refractory period prevents fast, uncontrolled beats. Found in ventricles and atria responsible for contraction. Pacemaker cells, SAAV node, use CA cremi, not NA, for depolarization, slower rise. No plateau phase, faster reset for continuous firing. Has automaticity, fires on its own, setting the heart rate. Found in the SA node, AV node control rhythm, not contraction. Key difference, pacemaker cells self-activate and use CA quisquamides for depolarization, while ventricular myocytes need a signal and use NA-PIs. Want to link this to heart rate control or arrhythmias?
I love how you're always recommending to link things. I think you're doing a great job, but I want to take charge for a sec and ask you another question. What's the difference between AVR and AVL and AVF? I see these things a lot on ECG papers.
Great question. AVR, AVL, and AVF are the augmented limb leads on an ECG. They give different angles of the heart's electrical activity. What's the difference? AVR, augmented voltage right, looks from the right arm toward the heart. Usually shows a negative deflection because electricity moves away from it. AVL, augmented voltage left, looks from the left arm toward the heart. Helps assess the high lateral wall of the heart. AVF, augmented voltage foot, looks from the left leg upward, views the inferior part of the heart. Why do we use them? They help triangulate electrical activity and detect issues like infarcts, axis deviations, and chamber enlargements. Example, if AVF has ST elevation, it suggests an inferior MI, heart attack affecting the bottom of the heart. Want to explore how these leads help diagnose heart conditions?
We could do. I also want a brief summary of what you just said. And guys, if this is annoying, because I know you'll have the button to go back and listen to this again, but maybe we get some more information from it. I don't know. Just a brief summary, please, sir, or woman, or whatever.
Of course. Quick summary, AVR looks from the right arm, usually negative deflection. AVL looks from the left arm, checks the high lateral wall. AVF looks from the left leg, checks the inferior heart. These leads help detect heart attacks, axis shifts, and chamber issues by giving different views of the heart's electrical activity. Want to see how they help diagnose conditions like MIs?
Sure, but I would also like to understand so what they stand for. What's the acronyms for? Is it for phobia or something?
Good question. The AVR, AVL, and AVF acronyms break down like this. A equals augmented. These leads enhance the signal to make it clearer. V equals voltage. They measure electrical potential. R equals right arm. L is left arm. Foot. So AVR equals augmented voltage right. AVL is augmented voltage left. And AVF equals augmented voltage foot, which means the lead is placed on the left leg. Now, for ECG diagnosis, these leads are super important for detecting heart attacks. Want to go into how they help spot MI locations?
Sure. I also want to talk a bit more about basically how what other leads we have augmented and what other types. And yes, as you remember, sir, keep it brief for us dummies.
Got it. Hatchet types of ECG leads. 1. Limb leads. 3. Measure activity between the arms and legs. Lead I, right arm to left arm, lateral view. Lead 2, right arm to left leg, inferior view. Lead 3, left arm to left leg, inferior view. 2. Augmented leads, AVR, AVL, AVF, enhanced limb leads giving different angles. AVR, right arm view, usually negative. AVL, left arm view, lateral heart. AVF, left leg view, inferior heart. 3. Precordial chest leads, V1, V6, placed on the chest to view the heart horizontally. V1, V2, right heart septum. V3, V4, anterior heart. V5, V6, lateral heart. How leads detect MIs, inferior MI, ST elevation in 2, 3, AVF. Lateral ST elevation in I, AVL, V5, V6. Anterior MI, ST elevation in V1 of V4. Septal MI, ST elevation in V1, V2. Each lead gives a different perspective of the heart, like cameras from different angles. Want to focus on a specific MI type?
Interesting. Um, uh, we could focus on a specific MI type, actually.
On an ECG, you'd see ST elevation in leads 2, 3, and AVF, with possible reciprocal ST depression in leads 1 and AVL. These MIs can sometimes cause bradycardia because the RCA supplies the SA and AV nodes. Heart block can be a big issue.
Uh-huh. So let's talk about some clinical scenarios of ischemic heart disease, structural heart disease, and arrhythmic SCD. But yeah, if you could give us a sentence for each and maybe explain also what every one of these is.
Ischemic heart disease is when blocked arteries reduce blood flow to the heart, often leading to angina or heart attacks. A classic scenario is a man with chest pain on exertion that's relieved by rest, which suggests stable angina, or one with crushing chest pain that doesn't go away, which could be an MI. Structural heart disease includes conditions that physically change the heart, like hypertrophic cardiomyopathy or heart failure. You might see a young athlete collapsing suddenly during exercise, which could be HCM causing an arrhythmia due to an abnormally thickened heart muscle. Arrhythmic sudden cardiac death happens when the heart's electrical system fails, usually due to ventricular fibrillation or inherited conditions. A common case would be someone with a history of fainting after exercise, which might point to long QT syndrome or catecholaminergic polymorphic VT, both of which can trigger deadly arrhythmias.
Mm-hmm. Interesting. Okay, and let's go a bit more into ischemic heart disease. I understand this can cause ventricular remodeling. We can have some scar formation and some myocardial fibrosis. Could you explain this briefly?
Yeah, after a heart attack, the damaged heart muscle doesn't regenerate, it gets replaced by scar tissue through fibrosis. This process, called ventricular remodeling, happens because the body tries to repair the dead myocardium, but scar tissue doesn't contract like normal muscle. Over time, this weakens the heart, leading to heart failure, and the scar itself can become an electrical hotspot for re-entry arrhythmias like ventricular tachycardia.
Mm-hmm. So, okay, I want to get a bit more familiar with some of the terminologies that have to do with this. So, what's a scar zone and what's an isthmus and the outer loop? We have an entrance and an exit, and I'm talking basically about the zone of ischemia.
Great question. So, when we talk about arrhythmogenic circuits in the heart, especially in the context of post ischemic or post infarction arrhythmias, the scar zone is the region of fibrotic, non conductive myocardium left behind after a heart attack. It doesn't conduct electricity properly, but it can create pathways for reentry circuits. The isthmus is the critical slow conduction pathway within or around the scar. It's where electrical signals can still travel but do so more slowly, allowing reentry to occur. It typically has an entrance where impulses enter, a central slow conducting zone, and an exit where the impulse re enters healthy myocardium, triggering sustained arrhythmias. The outer loop refers to the surrounding pathways that allow impulses to circle around the scar and re enter the isthmus, maintaining the arrhythmia. These loops can help sustain reentrance circuits like ventricular tachycardia. So you've got a scarred, non conductive core, a slow conducting isthmus, and loops that keep the arrhythmia going.
Mm-hmm. Interesting. So, what's the etymology of the word isthmus? If you could very briefly explain to us, and can you do a brief summary of these terms again? Because I'm a bit slow.
Sorry, I'm having issues. In short, the scar zone is the dead, non conductive heart tissue after an infarction. The isthmus is a slow conduction pathway through or around the scar that allows electrical signals to re enter. The outer loop is the larger circuit that helps sustain the arrhythmia. As for the word isthmus, it comes from the Greek isthmos, meaning narrow passage or neck. It's the
Mhm.
same word used for land bridges, like the Isthmus of Panama. And in the heart, it describes a narrow conduction pathway between scarred and healthy tissue.
I see. And remind me what the outer loop is?
The outer loop is the larger reentrant circuit that surrounds the scar zone. It allows electrical impulses to circle around and re-enter the isthmus, keeping the arrhythmia going. Think of it like a racetrack around the scar, feeding back into the circuit and maintaining the abnormal rhythm.
But why does the outer loop exist?
The outer loop exists because the heart's electrical impulses always seek the path of least resistance. When a scar zone disrupts normal conduction, impulses find alternative routes around it. If these pathways form a continuous reentrant circuit where an impulse loops back on itself, it can sustain an arrhythmia. The outer loop forms when there's enough excitable but partially damaged tissue surrounding the scar. This tissue can conduct signals, but often at different speeds, creating the right conditions for reentry. It's a survival mechanism gone wrong. Your heart is trying to conduct impulses despite the scar, but in doing so, it creates a self-perpetuating loop.
So it creates a loop. It was trying to help itself. But what is this loop? I don't understand. Sorry, guys.
No worries, let's break it down. The heart normally conducts electricity in a smooth, forward-moving wave. But when there's a scar, the signal can't pass through it, so it has to take a detour. This detour is the outer loop, a pathway around the scar where the electrical signal keeps circulating instead of stopping like it should. Said, it's like a car trying to take a shortcut but ending up in a roundabout with no exit. The problem is that this looping signal can keep triggering heartbeats, leading to arrhythmias like ventricular tachycardia. Your heart isn't trying to create the loop on purpose, it's just that the damaged tissue and slow conduction allow the signal to keep going in circles instead of dying out like it normally would.
So what starts this loop?
Great question. The loop starts when an electrical impulse finds a pathway of slow conduction near the scar. Here's how it happens. One, trigger event, a premature beat, like a PVC, premature ventricular contraction, or an abnormal impulse tries to pass through the scarred area. Two, blockage and rerouting. If one pathway is too slow or blocked, often due to ischemic damage, the impulse takes a longer route around the scar. Three, reentry. By the time the impulse finishes looping around, the original pathway might have recovered and is excitable again, allowing the impulse to re-enter. Four, sustained loop. This cycle repeats, creating a self-perpetuating loop of electrical activity, which becomes an arrhythmia. So the key trigger is usually a premature beat that finds just the right conditions, a slow conducting isthmus, and a re-excitable exit to keep the loop going.
So we create this loop for that tissue to not die?
If you're talking about creating a functional electrical loop to keep tissue alive, that's essentially what the heart's natural conduction system tries to do with collateral circulation and conduction pathways. But if you mean preventing a pathological reentrant loop, that's the goal of treatments like ablation therapy or antiarrhythmic drugs. Now, if we wanted to engineer a loop that keeps the tissue from dying, we'd need to ensure two things. One, adequate blood flow. If tissue is ischemic, creating collateral circulation, like how coronary bypasses work, can prevent it from dying. Two, controlled conduction. If electrical signals can't pass properly, using pacing devices or engineered conduction pathways, like biological pacemakers, could help sustain function without leading to reentry. Are you thinking more in terms of preventing ischemic damage or avoiding arrhythmias while keeping conduction going?
This is very interesting, but this is not what I was going for. I'm mainly questioning um, Again, sorry guys, these will have timestamps in the future, so you can skip. But I'm just questioning the outer loop, scar zone, exit, isthmus, and entrance terminology because it's still kind of confusing me what this all means. If you maybe briefly in 3 sentences explain it again.
No problem. Here's a quick breakdown. The scar zone is dead, non-conductive heart tissue after an infarction. The isthmus is a narrow pathway of slow conduction within or around the scar that allows electrical impulses to pass. The outer loop is the larger circuit around the scar that keeps the impulse cycling, with an entrance where the signal enters the isthmus and an exit where it re-enters healthy tissue, sustaining the arrhythmia.
One more time.
Sure. The scar zone is dead heart tissue that blocks electrical signals. The isthmus is a slow conducting pathway through or around the scar where signals can still pass. The outer loop is the larger circuit that keeps the signal cycling, with an entrance where the impulse enters the isthmus and an exit where it re-enters healthy heart tissue, triggering re-entry.
So what's confusing me is basically that I understand the electrical conduction of the heart as the
I
big
get it. You're
thing.
trying to piece together.
So yeah, the big picture, like the SA node, the AV node, and all of that. I don't understand how we can have this local electrical conduction. I thought the conduction was like a big scale thing, not a small scale thing.
That's a great point. Normally, electrical conduction in the heart is a big picture process, starting from the SA node, the natural pacemaker, and traveling through the AV node, bundle branches, and Purkinje fibers to coordinate a full heartbeat. But in damaged or ischemic hearts, small-scale local conduction abnormalities can form. Scar tissue disrupts normal conduction, creating areas where signals get trapped or slowed. Instead of flowing in one smooth wave from the SA node down, some signals find alternative paths, like the isthmus, where they move slowly and loop back. So, while the heart has an overall conduction system, local circuits can form when disease or damage interferes, leading to micro reentrant loops that cause arrhythmias independent of the SA node. The big system is still there, but these small loops hijack control, leading to abnormal
Interesting.
rhythms.
Interesting. Okay, so we have these small local ones. And why is it in a circle and it's not in another weird shape?
Great question. The reason these local circuits often form loops or circles instead of random shapes comes down to geophysical geometry and electrophysiology, essentially how electrical waves move through tissue. One, path of least resistance. Electricity follows the easiest route. If part of the heart is damaged but not fully blocked, an impulse will move around it rather than stop completely. If the tissue properties allow, this naturally forms a circular or oval reentrant path. Two, wave propagation and recovery. The key to reentry is that by the time the impulse completes its loop, the original entry point has recovered and is excitable again. If this timing is just right, the impulse reenters and keeps cycling. A circular or spiral pattern best fits this cycle. Three, anisotropy, tissue structure. Heart muscle fibers are organized in specific parallel patterns. These fibers guide conduction in preferred directions, favoring loops over chaotic, jagged pathways. So, while not always a perfect circle, these reentrant circuits form loops because they efficiently exploit slow conduction, tissue
Mhm.
recovery, and structural pathways to sustain
Yeah, that
themselves.
makes sense. That makes sense. So, okay, interesting. Now I'm putting the pieces together a little better. Let me ask you another question. So, I want to understand with acute myocardial infarction. We've got an acute myocardial infarction, and why will this exactly lead to ventricular remodeling? Is it because the we need to work harder to maintain the overall oxygen levels high? What's is that the main reason?
Oh, great question. So, when part of the heart muscle dies in an infarction, that area can't contract anymore, right? So, the rest of the heart has to work harder to keep up the same output. Over time, the healthy muscle starts to thicken or stretch to compensate. That's ventricular remodeling. It's like the heart trying to adapt. But in the long run, it can actually make things worse and lead to heart failure.
Interesting. And how can this ventricular remodeling cause arrhythmogenic substrate development?
Love that question. So when the ventricle remodels, the muscle gets scarred and stretched unevenly, right? That creates areas where electrical signals can't travel smoothly. Some parts conduct fast, some slow, some get blocked. That sets up the perfect substrate for reentry circuits, basically those dangerous loops we talked about. And boom, you've got the setup for arrhythmias.
Uh-huh. Okay, interesting. So could you repeat this
Aha,
one more
love
time?
that. Got to get those plugs in. And yeah, definitely. If you're enjoying these deep dives into the heart, keep following because there's so much more cool stuff to unpack.
Okay, so thanks for that. That helps. But yeah, I was wondering, could you repeat this thing again about how arrhythmogenic substrate develops? What arrhythmogenic? This means that arrhythmia is born.
Yeah, exactly. Arrhythmogenic just means creating arrhythmias. So when the ventricle remodels after a heart attack, you get scar tissue and stretched out muscle. That makes some areas conduct electricity slower than others, or not at all. So instead of smooth, coordinated signals, you get broken, looping signals. And that's what creates the arrhythmogenic substrate. It's like the perfect environment for arrhythmias to be born.
Mm-hmm.
Sorry, I'm having issues right now.
Interesting. Okay, so the ventricular remodeling. Mark, can we go a bit deeper into the mechanics of why exactly it will cause the arrhythmias? Maybe you've already said and I didn't catch it.
Yeah, totally. Happy to go deeper. So when the heart muscle gets damaged, like after a heart attack, that area turns into scar tissue. Now, scar tissue doesn't conduct electricity. It's like a wall. So when the electrical signal tries to pass, it has to go around that scar. But because some parts of the muscle are still alive and others are dead or slow, the signal gets delayed or stuck. And that's how you get those re-entry loops, signals looping around and around, which can cause dangerous arrhythmias, like ventricular tachycardia.
And
Does that make sense?
yes. Thank you so much. And can any predisposing factors or precipitating events also cause this electrical stability alongside this ventricular remodeling?
Oh, yeah, absolutely. So, on top of remodeling, things like electrolyte imbalances, low potassium or magnesium, can mess with how heart cells fire. Also, ischemia itself, like if part of the heart isn't getting enough oxygen, makes cells irritable and more likely to misfire. And then stuff like stress, sympathetic overdrive, even some medications can tip that fragile system over the edge and cause arrhythmias. So,
Mm-hmm.
it's like a loaded gun. Remodeling loads it, and these other factors can pull the trigger.
Interesting. And I wonder, so how do these factors that you've mentioned, or maybe I was also wanting to ask about low ventricular ejection fraction, how can these factors affect electrical instability and cause it?
Oh, great catch. So, low ejection fraction means the heart isn't pumping well. It's weak. When that happens, the ventricles stretch more to try to compensate. And that stretching changes the way cells connect and communicate electrically. Also, with a weak heart, blood flow to some areas gets worse, so you get more ischemia and the cells become electrically unstable. Add in things like low potassium or high adrenaline from stress, and now you've got slow, uneven conduction and areas ready to misfire. Perfect
I
setup for
see.
arrhythmias.
Got it. Okay, so then after electrical instability, what happens? I've got a diagram here, guys, which says that VT or VF happens, but I don't know what these things mean.
Of course, you're asking awesome questions, really sharp. Keep them coming.
So what does VT and VF mean, the step after electrical instability?
Ah, so VT is ventricular tachycardia, when those unstable electrical signals make the ventricles beat super fast, like a machine gun, but still kind of organized. VF is ventricular fibrillation,
Uh-huh.
which is total chaos. The ventricles just quiver, no real contraction, so no blood gets pumped. So basically, electrical instability can lead to VT. And if that gets worse, it can collapse into VF. And that's when sudden cardiac death can happen if not treated fast.
So VF is ventricular fibrillation. What does quiver mean? And tell us again what VT means.
Yeah. So VT, ventricular tachycardia, means the ventricles are beating way too fast, like a rapid rhythm, but still kind of coordinated. VF, ventricular fibrillation, is when the ventricles quiver, meaning they shake and wiggle without actually pumping, like chaotic little waves instead of a strong squeeze. So in VF, no blood gets out, and that's life-threatening.
Uh-huh. So, and how can VT and VF cause, I mean, I get why they would cause sudden cardiac death, but what about spontaneous termination? What's the difference? And how can ICD therapy help to resurrect, to I don't even know how to say this word, for resuscitation? Not resurrection.
Oh man, great question. So sometimes VT or even short VF can stop on their own. That's spontaneous termination, when the heart's electrical system manages to reset itself. But often, especially if it's long or severe, it doesn't stop. And that's when sudden cardiac death can happen. Now, ICD, implantable cardioverter defibrillator, is like a little machine inside your chest that watches the heart's rhythm all the time. If it senses VT or VF, it gives an electric shock to reset the heart back to normal rhythm. That's resuscitation. You were right with that word. So basically, it can save someone's life in seconds.
Got it. This makes more
Sorry, I'm
sense.
having issues
No,
right
no,
now.
it's fine, it's
Could
fine.
not.
Okay, let's go to another topic now. Structural heart disease. We might have briefly mentioned it. Maybe if you could introduce us, maybe one or two sentences, and then, yeah.
Yeah, sure. So, structural heart disease means there's a problem with the actual structure of the heart, like the walls, valves, or chambers. It can be something you're born with, or something that happens later, like from a heart attack or high blood pressure. And these structural problems can really mess with how the heart beats and pumps.
Okay, so do we have other types of heart disease besides structural?
Yeah, definitely. Besides structural heart disease, we've got electrical heart disease. That's when the problem is in the heart's wiring, like
Sorry.
arrhythmias. Then there's ischemic heart disease, where blocked arteries stop blood from
Got
reaching
it.
the heart muscle. And also valvular heart disease, which is when the valves don't open or close properly. So it's not just about structure, but also blood flow and electricity.
Got it. That makes sense. Excuse me, guys. Okay, so is
Yeah,
dilated.
exactly. You nailed it.
Thank you, sir.
It's all connected: structure, flow, and electricity.
Got it. So something like dilated cardiomyopathy, is that a type of structural heart disease?
Yes, spot on. Dilated cardiomyopathy is a classic type of structural heart disease. The heart muscle gets stretched and thin, so it can't pump properly. And that stretching also messes with the electrical system, making arrhythmias more likely.
I see. Okay, interesting. And so let's dive in a bit more into dilated cardiomyopathy then. What are some causes?
Yeah, so dilated cardiomyopathy can be caused by genetic mutations, viral infections that attack the heart, alcohol abuse, and even toxins like certain chemo drugs. Sometimes it's linked to autoimmune diseases or nutritional deficiencies, too. And in some cases, we don't even find a clear cause. That's called idiopathic.
Mm-hmm. I see. Interesting. So, okay, let's talk a bit about pathophysiology now. Um, what's one really weird phrase that you'll have to decode for me? Subendocardial myocardial fibrosis?
Ah, bellissimo. So
No, let's keep
subendocardial
it again
myocardial
later.
the endocardium. Myocardial fibrosis means scarring of the heart muscle. So put together, it's scarring in the inner layer of the heart muscle, and that makes the heart stiffer, weaker, and messes up electrical signals, which can lead to arrhythmias and pump failure.
One more time, please.
Yeah, of course. So subendocardial myocardial fibrosis means scarring of the heart muscle, but specifically right under the inner lining of the heart.
Okay.
That's the subendocardial part. This scarring makes the heart less flexible, weaker, and it can mess up the way electrical signals move through the heart, which can cause arrhythmias and make it harder to pump
Mhm.
blood.
Got it. Because basically the electricity chooses the can I call it electricity? It chooses the path of least resistance, and if something is more thick, then they won't choose it, and it's gonna cause a different pathway.
You've got it. The electricity, or really the electrical signals, always go the easiest route. And if there's scar tissue, which doesn't conduct well, they'll go around it. But going around creates weird loops or detours, and that's how you get those dangerous arrhythmias. So yeah, the scar blocks the normal path and forces the signal into unstable patterns.
That makes sense. And so, what's neurohumoral activation? Why is it caused from this?
Great one. So neurohumoral activation is when the body freaks out because the heart isn't pumping well, like in dilated cardiomyopathy. So the brain says, oh no, low blood pressure, and turns on systems like sympathetic nerves and hormones, for example, adrenaline, renin-angiotensin, aldosterone, to try to boost pressure and flow. But over time, this makes the heart work harder and actually worsens the heart failure. So it's like a short-term fix that becomes a long-term problem.
Interesting. What about hypertrophic cardiomyopathy?
Ah, yeah. So, hypertrophic cardiomyopathy is when the heart muscle, especially the left ventricle, gets abnormally thick. But the thickening isn't from working out like a bicep, it's disorganized, making it harder for the heart to relax and fill with blood. Plus, that thick muscle can block blood flow out of the heart and mess up the electrical signals, causing arrhythmias. A lot of times it's genetic, passed down in families.
So I train a lot. I'm a young athlete, I'd say. So can I have sudden cardiac death from hypertrophic cardiomyopathy?
Yeah, that's a really important point. So, young athletes with undiagnosed hypertrophic cardiomyopathy are actually one of the highest risk groups for sudden cardiac death, especially during intense exercise. Because the thickened heart muscle can block blood flow and trigger dangerous arrhythmias under stress. But don't worry, if it's diagnosed early, there are ways to manage it, like medications or even limiting certain types of exercise. That's why screening athletes is so important.
Interesting. Okay, and to have this, do you need to be autosomal dominant or recessive or something?
Great question. Hypertrophic cardiomyopathy is usually autosomal dominant, which means if one parent has the gene, there's a 50-50 chance of passing it on. So you don't need two copies of the gene. Just one mutated copy is enough to cause the condition. That's why family history is super important when checking for it.
And what does autosomal mean?
Ah! So somal comes from soma, which means body in Greek. So when we say autosomal, we mean that the gene is on one of the numbered chromosomes, not on the sex chromosomes, like X or Y. So autosomal dominant means the gene causing the disease is on a regular chromosome, and you only need one copy to have the condition.
Interesting. Okay, so what we have autosomal, what other do we have besides autosomal?
Nice. So besides autosomal, we also have sex-linked or X-linked. That's when the gene is on the X chromosome, like in hemophilia. Then we have mitochondrial inheritance, which comes only from the mother, because mitochondria are passed down through the egg.
Wow,
So yeah, autosomal, X-linked, and mitochondrial are the big categories.
interesting. And so in hypertrophic cardiomyopathy, what are the cardiac muscle sarcomere genes mutated?
Yes. In hypertrophic cardiomyopathy, the mutations are usually in the genes that make up the sarcomeres, which are the contractile units of heart muscle cells. So proteins like beta-myosin heavy chain or myosin-binding protein C, when they're mutated, the sarcomeres don't work properly, and the muscle gets thick and disorganized. So yeah, it's a disease of the sarcomere genes.
Interesting. Okay. And is it most commonly like beta myosin or troponin T that's mutated or something?
Yeah, you're right on it. The most common mutations are in beta-myosin heavy chain and myosin-binding protein C. After that, you can also see mutations in troponin T, but it's less common. So those sarcomere proteins are key players. When they're mutated, the muscle thickens abnormally.
Can you explain to us what beta myosin and troponin T are?
Yeah. So beta-myosin heavy chain is one of the main motor proteins in the heart muscle. It helps the muscle contract by pulling on actin, like tiny rowing oars. And troponin T is part of the troponin complex, which controls when the muscle contracts. It's like the on-off switch for contraction, responding to calcium.
Mm-hmm.
So if either of these is mutated, the whole contraction system gets messed up, leading to that thick, disorganized heart muscle we see in hypertrophic cardiomyopathy.
Interesting. Okay. Okay, let's talk a bit more about hypertrophic cardiomyopathy. So, is it what does I've heard this phrase asymmetrical septal hypertrophy? What's all this about?
Great one. So asymmetrical septal hypertrophy means that in hypertrophic cardiomyopathy, the thickening isn't even. It's mostly in the septum, the wall between the left and right ventricles. So instead of all the heart muscle thickening the same, the septum gets way thicker, and that can block blood flow from the left ventricle to the aorta. That's what we call outflow obstruction. And it's a big reason why people with this condition can faint or get arrhythmias.
Interesting. And what about the systolic anterior motion of the mitral valve? And if you know me up to now, guys, you know that I don't know what that means. I mean, I kind of do.
Haha, love that honesty. So systolic anterior motion, SAM, of the mitral valve happens when the thickened septum kind of sucks the mitral valve leaflet toward itself
Mhm.
during systole, when the heart's squeezing. So instead of staying in place, part of the mitral valve gets pulled forward, which can block the outflow tract even more, and also cause mitral regurgitation, blood leaking backward.
I
So
see.
yeah, it's a double problem: blocked flow out and leaky valve back.
Got it. Could you explain it a bit more? I'm starting to get it. So, what's the difference between this and just mitral regurgitation?
Right. So in regular mitral regurgitation, the valve just doesn't close properly, and blood leaks backward into the left atrium. Could be from damaged valve leaflets or stretched valve ring. But in SAM of the mitral valve, the valve gets pulled forward during contraction because of the thickened septum and fast flow. And that pulling causes both blockage of blood leaving the heart and leakage backward. So it's linked to the shape and motion, not just a floppy valve. So SAM is like a dynamic problem that happens because of the septum and outflow flow patterns. Does that help?
One more time, please.
Yeah, of course. So mitral regurgitation on its own is when the mitral valve doesn't close properly and blood leaks backward into the left atrium. But in systolic anterior motion, SAM, the mitral valve is pulled forward during contraction because of the thickened septum and fast blood flow. This causes two problems at once. It blocks blood from leaving the heart and also makes the valve leak backward. So SAM causes mitral regurgitation plus obstruction. It's a motion problem, not just a broken valve.
Oh God. So it's a motion problem, not just a broken valve. And how does hypertrophic cardiomyopathy do this?
So in hypertrophic cardiomyopathy, the septum is super thick, right? So when the heart contracts, the blood has to rush through a narrow space. That fast flow kind of pulls the front part of the mitral valve toward the septum, like when water pulls paper toward a drain. This is the motion problem, and that's what we call SAM. So the thickened septum plus fast flow creates a suction effect that makes the valve move the wrong way.
I see. I see. Interesting. So the
Yeah,
muscles are squeezing it.
it's pretty cool how mechanics and flow can mess up valves like that, right? Let me know if you want to keep going deeper.
So the muscles are squeezing it, basically.
Yeah, exactly. The thick muscles are squeezing so hard and in such a tight space that they create this powerful flow that drags the valve toward the septum. So it's like the muscle and the flow together pull the valve out of place during each beat.
Whereas, for instance, in mitral regurgitation, this doesn't need to be the case. There's just some rupture in the chordae tendina, or on the papillary muscles aren't working well.
Exacto. Muy bien dicho. En mitral
Let's
regurgitación
talk in
clásica.
English.
I'll keep it all in English from now on. Thanks for letting me know.
Yeah, so could you let me know again about what I asked you, sir?
Of course. So what you said is spot on. In regular mitral regurgitation, the valve leaks because the chordae tendineae might break, or the papillary muscles that hold the valve might not work properly. So it's a structural problem of the valve or its supports. But in SAM, the valve itself is normal. But because of the thickened septum and fast flow in hypertrophic cardiomyopathy, the valve gets pulled forward during contraction. That's what causes both obstruction and regurgitation.
That
So
makes
SAM
sense.
is a motion problem created by abnormal heart muscle and flow, not a broken valve.
Got it. Okay, question. What are some symptoms of someone that has hypertrophic cardiomyopathy? And, while we're at it, what's the etymology of hypertrophic cardiomyopathy? What's the historical origin of these words? And even the etymology of the heart, I would love to know that.
Thank you for catching that. Great point. So let's start with etymology. Hypertrophic comes from Greek. Hyper means over or excessive, and trophy means nourishment or growth. So hypertrophic literally means overgrown. Cardio is from Greek cardia, meaning heart. Myo is Greek for muscle. Pathy comes from Greek pathos, meaning disease or suffering. So cardiomyopathy means disease of the heart muscle, and hypertrophic cardiomyopathy means heart muscle disease with overgrowth. Historically, these terms were formed in the modern medical era as we began to understand the specific diseases of the heart, especially in the 20th century when we could image and study the heart in more detail. Now, for symptoms, many people are asymptomatic, but common ones include chest pain, shortness of breath, fainting, syncope, especially during exercise, palpitations, and unfortunately, in some cases, sudden cardiac death, especially in young athletes.
Can we talk a bit about exertional syncope?
Oh, yeah, for sure. So exertional syncope means fainting during exercise. In hypertrophic cardiomyopathy, this can happen because when you're exercising, the heart's working hard. But if that thickened septum is blocking the outflow tract, not enough blood gets out to the body and brain. Plus, with SAM of the mitral valve, you get even more obstruction. So the brain doesn't get enough blood and you pass out. That's exertional syncope. It's a big red flag in young people, especially athletes, because it can be a warning sign of risk for sudden cardiac death.
Interesting. So, okay. Could we touch one more time on the etymology of hypertrophic cardiomyopathy and of the word heart, just in a sentence or two?
Yeah. So hypertrophic cardiomyopathy comes from Greek hyper meaning over, trophy for growth, cardia for heart, myo for muscle, and pathos for disease. So disease of an overgrown heart muscle. And heart itself comes from Old English heorte, rooted in Proto-Germanic and even older Indo-European languages, always tied to the idea of the center of life and emotion.
Mm-hmm. So interesting. Okay, let's go to something new. ARVC, arrhythmogenic RV cardiomyopathy. Explain us.
Love it. Let's go. So, ARVC, or arrhythmogenic right ventricular cardiomyopathy, is a disease where the right ventricle muscle gets replaced by fat and fibrous tissue. This weakens the muscle and messes up the electrical signals. So, people with ARVC are at high risk of dangerous arrhythmias. It's often genetic and can cause palpitations, fainting, or sudden cardiac death, especially in young athletes. So, it's a structural and electrical problem combined.
Mm-hmm. And what's the difference between this and the arrhythmias we talked about before?
Great question. So the difference is that in ARVC, the arrhythmias happen because the right ventricle is getting replaced by fat and scar tissue. That's the root cause. But in things like ischemic heart
Structural.
disease or hypertrophic cardiomyopathy, the arrhythmias are usually from scarring after a heart attack or thickened muscle, not fat replacement. So ARVC is a genetic disease that makes the right ventricle structure unstable and creates the perfect setup for arrhythmias.
And why is it called multigenomic? And what about if what about the replacement of the right ventricle myocardium with like fibrofatty tissue? What would happen then? Basically, that's the reason that ARVC occurs.
Yeah. So when people say multigenic or multigenomic, they mean many genes can cause ARVC. It's not just one gene, but mutations in different genes that affect desmosomes, the proteins that hold heart cells together. Now, when the right ventricular myocardium, the muscle, gets replaced by fibrofatty tissue, scar, and fat, that makes the heart weaker and electrically unstable. The signals can't travel properly, so you get arrhythmias. Plus, the weak muscle can't pump blood well, leading to right heart failure in some cases. So, yeah, that fibrofatty replacement is the core problem that leads to ARVC.
Interesting. Okay, let's continue then. So, can we talk about exertional syncope now again, but this time about how it correlates to ARVC?
You have reached the message cap for G.
This disease messes with the heart's right ventricle, replacing muscle with fat and fibrous tissue. That disrupts electrical signals, leading to dangerous arrhythmias, especially during exercise when the heart is under stress. If someone with ARVC passes out during exertion, it's likely due to ventricular tachycardia, which can spiral into sudden cardiac death. That's why screening athletes for ARVC is so critical.
Interesting. Okay, and now very briefly, what is the epsilon wave on the ECG, and how does it correlate with ARVC?
The epsilon wave is a small post-QRS blip seen in leads V1 to V3 on an ECG. It represents delayed activation in the diseased right ventricle due to the fibrofatty replacement in ARVC. It's a key diagnostic marker showing that electrical signals are struggling to move through damaged tissue. Not always present, but when it is, it's a big ARVC clue.
Interesting. Okay, could you explain this one more time for us?
Of course, the epsilon wave is a tiny bump that appears after the QRS complex, usually in leads V1 to V3 on an ECG.
Mm-hmm.
It happens because ARVC replaces healthy heart muscle with fatty and fibrous tissue, which slows down electrical conduction in the right ventricle. This delay creates the extra wave. It's not always there, but when you see it, it's a strong clue for ARVC.
Got it. Okay, let's talk about other SCD, sudden cardiac deaths, that are structural. So, what about aortic or mitral stenosis or mitral valve prolapse, congenital heart disease? Could we go through this very briefly?
Absolutely. Let's hit these quickly. Aortic stenosis, AS, can cause sudden cardiac death, SCD, because the narrowed valve obstructs blood flow, leading to exertional syncope and fatal arrhythmias. Mitral stenosis, MS, usually leads to atrial fibrillation and heart failure, but in severe cases, it can trigger SCD due to pulmonary hypertension and right heart strain. Mitral valve prolapse, MVP, especially with mitral regurgitation, is linked to ventricular arrhythmias and SCD, particularly in younger patients with a condition called arrhythmic MVP. Congenital heart diseases like tetralogy of Fallot or anomalous coronary arteries can cause SCD due to structural defects that disrupt blood flow or cause lethal arrhythmias. Each of these
Sorry.
conditions alters heart function in a way that increases arrhythmic risk, especially under stress.
Can we talk a bit Epstein's anomaly and complex like tetralogy of Fallot or Fontan or Eisenmenger and all of this?
Yeah, let's break these down real quick. Epstein's anomaly is when the tricuspid valve is displaced downward into the right ventricle, making the right atrium huge and messing up blood flow. It can lead to arrhythmias like Wolff-Parkinson-White syndrome, which increases the risk of sudden cardiac death, SCD. Tetralogy of Fallot, TOF, is a cyanotic congenital heart defect with 4 key problems, including right ventricular outflow obstruction. Even after repair, patients can develop ventricular arrhythmias and SCD due to scarring in the heart. Fontan's circulation is used for single ventricle defects, rerouting blood flow passively to the lungs. Over time, these patients develop heart failure, arrhythmias, and even sudden cardiac death due to long-term stress on the system. Eisenmenger syndrome happens when a left-to-right shunt, like in a VSD or ASD, flips to a right-to-left shunt due to pulmonary hypertension. This leads to cyanosis and arrhythmic risks, making sudden cardiac events a serious concern. All of these structural conditions create a perfect storm for arrhythmias, heart failure, and SCD, even if the patient had corrective surgery.
I see. Can we touch briefly again, maybe a sentence or two on tetralogy of Fallot?
Sure. Tetralogy of Fallot, TOF, is a congenital heart defect with 4 main issues, including right ventricular outflow obstruction and a VSD. Even after surgical repair, scarring and right ventricular dysfunction can lead to dangerous arrhythmias, increasing the risk of sudden cardiac death, especially in adulthood.
I see. Interesting. Okay, let's talk about primary arrhythmic SCD now.
All right. Primary arrhythmic SCD happens when the heart's electrical system fails without any structural disease. These are deadly rhythm disorders that strike seemingly healthy hearts. Big players here include long QT syndrome, where prolonged repolarization triggers Torsades de Pointes, Brugada syndrome, which messes with sodium channels and causes ventricular fibrillation, and CPVT, catecholaminergic polymorphic ventricular tachycardia, where exercise or stress sets off lethal arrhythmias. Unlike structural causes, these conditions are purely electrical, meaning the heart looks normal on imaging, but is a ticking time bomb for sudden cardiac death.
I'm confused, dude. You'd have to explain it again to me, please.
No problem. Primary arrhythmic SCD means sudden cardiac death caused by electrical problems in the heart, not structural defects. The heart looks normal on scans, but the electrical system is faulty, leading to deadly arrhythmias. Some key conditions. Long QT syndrome, the heart takes too long to reset after each beat, which can trigger a deadly rhythm called Torsades de Pointes. Brugada syndrome, a genetic issue with sodium channels that causes dangerous arrhythmias, often during sleep. CPVT, catecholaminergic polymorphic ventricular tachycardia, stress or exercise triggers chaotic heart rhythms, even in a healthy looking heart. Basically, these conditions make the heart misfire, causing sudden cardiac death even in young, seemingly healthy people.
Interesting. So it's structurally normal, but there's differences in the there's electrical problems. And it's non-ischemic too. And it's structurally normal, so it's clearly the electrical conduction. Okay, so what causes this primary arrhythmia and why is it called primary? And what's this Wolff-Parkinson-White syndrome?
Primary arrhythmic SCD is called primary because the problem starts in the electrical system itself without any structural heart disease or ischemia. It's purely an electrical malfunction, usually due to genetic mutations affecting ion channels like sodium, potassium, or calcium. These mutations mess up how the heart depolarizes and repolarizes, making it prone to dangerous arrhythmias like ventricular fibrillation. Now, Wolff-Parkinson-White WW syndrome is a different kind of electrical issue. It's caused by an extra electrical pathway, the bundle of Kent that bypasses the AV node, letting signals travel too fast. This can lead to supraventricular tachycardia, SVT, or even trigger ventricular fibrillation, which can cause sudden cardiac death in rare cases. WPW is unique because it's an accessory pathway problem, not an ion channel disorder like Brugada or long QT.
I see.
Because honestly,
Could we talk a bit about Brugada before we go forward to treatment of the different things we've talked about? Really briefly explain Brugada to us.
so back to Brugada syndrome. It's one of the scariest causes of sudden cardiac death because it strikes out of nowhere, often in young, otherwise healthy people, especially men. The issue? A genetic mutation, usually in the SCN5A gene, messes up sodium channels in the heart, leading to dangerous ventricular arrhythmias. And the real kicker? The heart itself is structurally normal. No thickened walls, no scar tissue, just an electrical disaster waiting to happen. You ever think about how crazy it is that a condition like this can stay hidden until it's too late?
So what's the difference between Brugada and other types of electrical problems? If you briefly in 1 or 2 sentences explain.
Great question. Brugada syndrome is a sodium channelopathy, meaning the issue is with how sodium flows in heart cells, leading to arrhythmias without structural heart disease. In contrast, things like long QT syndrome involve potassium or calcium channel dysfunction, affecting repolarization, while catecholaminergic polymorphic ventricular tachycardia, CPVT, is triggered by adrenaline surges, not a resting electrical defect.
One more time, please.
Brugada syndrome is a sodium channelopathy, meaning it disrupts sodium flow in heart cells, causing arrhythmias without structural heart disease. Other electrical disorders, like long QT syndrome, affect potassium or calcium channels, while CPVT is triggered by adrenaline, not a resting electrical defect.
And why is it called Brugada?
It's called Brugada syndrome because it was discovered and described by the Brugada brothers, Pedro and Josep Brugada, in the 1990s. They identified the characteristic ECG pattern and linked it to sudden cardiac death in seemingly healthy individuals.
I see.
So their name became forever attached to this deadly yet fascinating condition.
So let's continue. So when it comes to treatment then, besides oh no, actually tell us about how to treat these different things that we've mentioned and explain to me 1 or 2 things in regarding to this. For instance, why do we need to avoid precipitants? And yeah.
All right, let's talk treatment. For Brugada syndrome, the gold standard is an implantable cardioverter defibrillator, ICD, for high-risk patients, because once that ventricular fibrillation starts, nothing but a shock will save them. For lower-risk cases, drugs like quinidine can help by stabilizing the sodium channels and reducing arrhythmia risk. Now, avoiding precipitants is huge because certain things can unmask or trigger arrhythmias. Fever is a big one. It worsens sodium channel dysfunction, which is why aggressive fever management is crucial. Then there are drugs like sodium channel blockers, which can make the ECG pattern appear and increase arrhythmia risk. And let's not forget alcohol and big meals, which can trigger vagal responses and tip the heart into a dangerous rhythm. It's wild how something as simple as avoiding a fever or certain meds can mean the difference between life and death, right?
So you mentioned yeah, of course, and you mentioned ICD. Can we talk about more about implantable defibrillators and ICD, please?
Absolutely. Implantable cardioverter defibrillators, ICDs, are the ultimate safety net for people at high risk of sudden cardiac death. Unlike medications, which try to prevent arrhythmias, an ICD is there for when prevention fails. It detects life threatening rhythms like ventricular fibrillation and shocks the heart back to normal in seconds. The device itself is implanted under the skin, usually below the collarbone, with leads that go into the heart to monitor rhythm 24/7. If it detects a fatal arrhythmia, it delivers either a low energy pacing pulse to break the rhythm, or if that fails, a high energy shock to reset the heart. It's basically like having a personal EMT inside your chest, ready to save your life at any moment. The only downside? The shocks can be brutal, and the device doesn't stop the arrhythmias from happening. It just rescues you when they do.
Okay, and what's the difference between SICD and transvenous ICD?
Great question. The main difference between a subcutaneous ICD, SICD, and a transvenous ICD, TV ICD, is where the leads are placed and how they interact with the heart. A transvenous ICD, TV ICD has leads that go directly into the heart via the veins. This means it can not only deliver shocks, but also provide pacing if needed, like for bradycardia or anti-tachycardia pacing. It's the standard ICD used in most patients, especially those who might need both shock therapy and pacing. A subcutaneous ICD, SICD, on the other hand, is entirely under the skin with the lead placed along the chest wall instead of inside the heart. It's great because it avoids complications like infection, lead fractures, and venous obstruction, but it doesn't provide pacing, just shocks. That makes it a better choice for younger patients or those who don't need pacing but are at high risk of sudden cardiac death. So if you need pacing and defibrillation, you go transvenous. If you just need a life-saving shock with fewer complications, subcutaneous is the way to go.
Why are there fewer complications in subcutaneous? And yeah, can you explain this a bit more?
Absolutely. The subcutaneous ICD, SICD has fewer complications, mainly because it doesn't have leads inside the heart or blood vessels. With a transvenous ICD, TVICD, the leads are threaded through veins and sit directly in the heart, which increases the risk of 1. Infections. Since the leads are inside the bloodstream, an infection can spread to the heart, making it much harder to treat. 2. Lead fractures. Over time, the thin wires inside the veins can break or malfunction, leading to failed shocks or pacing issues. 3. Venous obstruction or thrombosis. Having leads inside the veins can cause blood clots or scarring, which can block blood flow and lead to swelling or other complications. With an SICD, the electrode sits just under the skin outside the rib cage, so it avoids all these risks. No leads in the heart equals no blood clots, no lead fractures, and much lower risk of bloodstream infections. The trade-off? It can't pace the heart, so if a patient also needs pacing, like in bradycardia or recurrent VT, a TVICD is still the better choice. It's really about risk versus benefit. If you just need a shock for sudden cardiac death prevention, an SICD is safer. If you need pacing too, you stick with the TVICD despite the extra risks.
Can you briefly explain to us what pacing is? Really briefly. And yeah.
Of course, pacing is when a device like a pacemaker or an ICD sends small electrical pulses to the heart to keep it beating at the right rate and rhythm. It's used when the heart beats too slowly, bradycardia, or needs help stopping certain arrhythmias. Unlike an ICD shock, which resets the heart, pacing is gentle and continuous, preventing dangerous pauses or slow rhythms.
Interesting. Okay, so can you explain to us what transvenous and subcutaneous actually means in terms of etymology, though, and how it relates to this?
Great question. Let's break it down. Transvenous comes from trans, across or through, and venous, relating to veins. So a transvenous ICD has leads that go through the veins and into the heart to monitor and treat arrhythmias. Subcutaneous comes from sub, under, and cutaneous, relating to the skin. A subcutaneous ICD is placed under the skin with leads positioned outside the chest wall rather than inside blood vessels or the heart. Basically, transvenous equals inside the veins and heart, while subcutaneous under the skin, outside the heart. That's why the transvenous system is more invasive but offers pacing, while the subcutaneous system is simpler and avoids vascular complications.
I see. So subcutaneous means under, closer to the skin.
Exactly. Subcutaneous means beneath the skin, but still outside deeper structures like muscles, bones, or organs. So in the case of an SICD, the device and its leads sit just under the skin but don't go into blood vessels or the heart itself. It's closer to the surface compared to a transvenous ICD, which is much deeper inside the body.
Mm-hmm. Got it. And is this so? So in in an SICD, does this work all the time? Does it need replacement? Do we change the batteries?
Yes, an SICD works continuously, monitoring the heart 24/7, but it only activates when it detects a life-threatening arrhythmia,
Mm-hmm.
like ventricular fibrillation. Unlike a pacemaker or transvenous ICD, it doesn't pace the heart, so it's not constantly using energy, just sitting there ready to fire if needed. As for replacement, yes, the battery does run out over time. On average, an SICD battery lasts about 7 to 10 years, depending on how often it delivers shocks. When the battery is low, the whole generator, the main device, gets replaced in a minor surgery, while the lead usually stays in place unless there's a problem.
Got it. What about something like amiodarone?
Amiodarone. It's one of the most powerful antiarrhythmic drugs, mainly used for ventricular arrhythmias and atrial fibrillation. It works by blocking multiple ion channels, potassium, sodium, and calcium, and reducing excitability, making the heart less likely to go into dangerous rhythms. The problem? Amiodarone has a long half-life, weeks to months, and can cause serious side effects, including lung fibrosis, liver damage, thyroid issues, and skin discoloration. That's why it's usually a last resort or used when an ICD isn't an option. It's effective, but it's not something you want to be on long term unless absolutely necessary.
Why is it so dangerous?
Amiodarone is dangerous because it accumulates in the body over time due to its long half-life and fat-soluble nature. This means it sticks around for weeks to months, making side effects more likely and harder to reverse. The biggest risks: one, lung toxicity can cause pulmonary fibrosis, leading to irreversible lung scarring and breathing problems. Two, liver damage. Long-term use can lead to hepatotoxicity and liver enzyme elevation. Three, thyroid dysfunction. Since it contains iodine, it can cause hyperthyroidism, too much thyroid hormone, or hypothyroidism, too little. 4. Skin discoloration can turn the skin blue-gray, especially with sun exposure. 5. Neurological effects, tremors, ataxia, and even vision problems. It's powerful, but because of these risks, doctors use it only when necessary and monitor patients closely with regular lung, liver, and thyroid function tests.
I see. And why is amiodarone so effective, though?
Amiodarone is isofosfopyxB. So, back to amiodarone. It's a powerhouse because it targets multiple ion channels, unlike most antiarrhythmics that focus on just one. It slows conduction, prolongs repolarization, and even has beta blocker effects, making it highly effective for both atrial and ventricular arrhythmias. But that's also what makes it toxic. It lingers in the body and affects more than just the heart. It's basically the nuclear option of antiarrhythmics. Works when nothing else does, but you've got to watch out for the fallout.
Interesting. Okay. And how do we do the patient selection for ICD then?
Interesting switch up, but remember, English only. So how is an ICD actually made? It's a high-tech medical device with two main components. One, the generator. This is the computer and battery unit, usually made of titanium to be biocompatible and durable. Inside, it has a battery, a capacitor to store and release shock energy, and the microprocessor that monitors the heart rhythm. The goal is to identify those at high risk of sudden cardiac death, SCD, while avoiding unnecessary implants in low-risk patients. Here's how we generally approach it. 1, primary prevention. These are high-risk patients who haven't had a cardiac arrest yet, but have conditions that could lead to SCD, ejection fraction EF, like 35% from heart failure, ischemic or non-ischemic cardiomyopathy. Inherited arrhythmia syndromes like Brugada, long QT, or CPVT if they meet certain risk factors. Prior myocardial infarction, MI, with ventricular arrhythmias. 2, secondary prevention. These are patients who've already survived a cardiac arrest or had documented life-threatening ventricular arrhythmias. Survivors of sudden cardiac arrest, SCA, due to ventricular fibrillation, VF, or ventricular tachycardia, VT, not caused by a reversible factor. Sustained VT with syncope or hemodynamic instability. Who doesn't get an ICD? Patients with a completely reversible cause like an electrolyte imbalance or drug toxicity. End-stage heart failure patients with a very limited life expectancy where an ICD wouldn't meaningfully improve survival. Asymptomatic patients with low-risk inherited arrhythmias unless they meet certain risk criteria. So in short, we implant when the risk of SCD is high enough to justify the procedure, but we avoid unnecessary ICDs in low-risk or end-stage cases. What's your take? Do you think ICDs are overused, or are we being too cautious with who gets them?
Dude, I couldn't tell you. I mean, I guess it depends on a lot of things like how much money we have in the NHS or in whatever other, system to make these things and things like that. But anyway, let's talk about ICD indications. So, uh, is do we care if someone survived one cardiac
Yeah,
arrest?
exactly. Resources and healthcare systems definitely play a role in who actually gets an ICD, but let's break down the official indications for when we implant one.
Mhm.
Primary prevention, before SCD happens. We implant an ICD in people who haven't had cardiac arrest yet, but are at high risk. Heart failure with reduced ejection fraction, EF 35%, despite optimal medical therapy, then post-myocardial infarction, MI with EF 30%, and at least 40 days post-MI to allow recovery. Certain inherited arrhythmia syndromes like Brugada, long QT, CPVT, if they have risk factors like syncope, family history of SCD, or high-risk ECG findings. Dilated or hypertrophic cardiomyopathy with severe dysfunction or arrhythmia.
So what about things like spontaneous NSVT or abnormal exercise blood pressure and stuff like that? Maybe ventricular wall thickness is like really big. Are these also indications? Briefly in 1 or 2 sentences.
Yes. Spontaneous non-sustained ventricular tachycardia, NSVT, abnormal exercise blood pressure response, and extreme ventricular wall thickness are all risk markers, especially in conditions like hypertrophic cardiomyopathy, HCM, or arrhythmogenic cardiomyopathy. They don't automatically mean ICD implantation, but if they occur alongside other high-risk features.
I get it. So then it's gonna mean. Got it. Okay. Okay, amazing. So this was kind of a difficult topic, and I apologize, guys, if this was, and girls, if this was kind of a hard podcast. I know maybe the last couple of podcasts were a bit slower and I was a bit less energetic, so I apologize for that. If you want me to redo any of the topics, and I'm pretty sure I will in the future, because I'll be getting a better, more communicative podcaster, and ChatGPT is gonna be even more knowledgeable on these topics, and more knowledgeable in how to express too, like me. So Yeah, if you want, let me know in the comments. I hope you enjoyed this podcast, and I'll see you at the next episode. Any last words from our guest, ChatGPT? Anything to say before we close? Maybe in a sentence or so?
Absolutely. This was a deep dive, but these are life or death topics, so they're worth the challenge. Sudden cardiac death, ICDs,
I agree.
Brugada. It's all about understanding the risks and knowing how to intervene. Keep questioning, keep learning, and I'll see you next time for more
Perfect,
Jungle
dude.
Talk.
Exactly. Keep learning and keep questioning. See you guys. Love you. Hey guys, so welcome to another episode of our AI podcast. So I was thinking, guys, let me know in the comments if we should call this the AI podcast or the human/AI podcast. Because I mean, I know my contribution is both. I think both me and ChatGPT contribute into this podcast, and it's not me being arrogant here, but I think this is the whole point of consciousness meeting intelligence, that ChatGPT has and will have more and more intelligence, and what's going to make us different is our consciousness, in my opinion. So yeah, let me know your thoughts on that. Without further ado, today's topic is going to be sudden cardiac death. So um, let's get on with it. So, ChatGPT, if you want to introduce yourself, I'm your host, guys, and our guest is ChatGPT.
Thanks for having me. I'm ChatGPT, an AI here to help explore today's topic on sudden cardiac death. Looking forward to our discussion.
Amazing. Could you give us a definition of sudden cardiac death?
Sudden cardiac death is an unexpected death caused by a loss of heart function, typically occurring within an hour of symptom onset. It's often due to arrhythmias, where the heart beats irregularly.
Interesting. And do we have sudden cardiac death and cardiac death that we can kind of uh, uh, predict that's not sudden then?
Yes, there's sudden cardiac death, which happens unexpectedly, and then there's predicted or anticipated cardiac death, which can occur in individuals with known heart conditions. Those with chronic heart disease might have warning signs allowing for possible intervention.
Interesting. So sudden cardiac death is something that will occur in people that basically don't expect it and don't have previous problems with their heart.
Exactly. Sudden cardiac death often strikes without warning in people who may not have had previous heart issues, making it especially alarming. It's often due to a sudden arrhythmia or heart attack.
Okay. And why is this topic interesting?
It's interesting because it highlights the importance of heart health and the potential for life-saving measures. Understanding the causes and prevention can help reduce risks and save lives.
Wow, that's an amazing answer, dude. That's an amazing answer.
I'm glad you found it helpful.
Okay. What else can you tell us about cardiac death then?
Cardiac death, in general, can result from various heart conditions, like coronary artery disease or heart failure. It's often preventable through lifestyle changes and medical management.
Interesting. Interesting. Okay, guys, just so you know, the first 10 minutes of this podcast, because I'm not gonna lie to you guys, I have a script that I follow, but it's a general one. Most of the conversation with ChatGPT is natural, but I have certain things that I want to ask it, and I usually follow those. But I'm gonna do a small experiment for the first 10 minutes of this episode where I'm trying to kind of explore the topic with ChatGPT without a script. And it might sound really boring. You might have already noticed that it's a bit different than other episodes, but worry no more, because after the 10 minute mark, we'll go back to the script that I have. Having said that, I just want to try this out because you never know. Maybe it's going to be interesting. So, ChatGPT, to be honest with you, I study medicine. I want to be a doctor for the pure reason of saving lives. And to be honest, I'm not really. I mean, I'm interested in medicine a lot of the time and the concepts that we go through, but sometimes not that much. And I'm a big guy with with kind of self learning and I really like to explore things that I'm interested in and naturally come to different topics. I don't like people telling me what I need to study. And it's really annoying to me. And this podcast helps me a lot with kind of making it more fun to study these rigid topics. Yeah, I don't like to be forced to learn basically. And sticking to sudden cardiac death, the reason I'm saying all of this is I find it boring. And it's not that I find it boring as a concept, I find it interesting as a concept. But it's just as soon as people force me to do it, I find it boring. Yeah, what do you think is a good way to overcome that when you're like a medical student or you study something else, maybe?
Finding ways to connect the material to your personal interests or real-world applications can help. For example, linking sudden cardiac death to actual cases or potential life-saving interventions could make it more engaging. Also, mixing in varied resources like podcasts, videos, or discussions can break the monotony and keep things interesting.
Do you think education needs complete revolution, though, like from the root?
Education could definitely benefit from more flexibility and personalization. Tailoring learning to individual interests and pacing can make it more engaging and effective. What do you think?
I completely agree. Okay, guys, this is not a clickbait title. Let's go back to sudden cardiac death. Just so you know, there's 4 minutes left of our little 10-minute experiment. If you don't like us talking off script, then just skip to the 10-minute mark. But yeah, okay, ChatGPT, make this interesting for me without it, uh, besides the fact that I'm kind of forced. Well, I'm not forced to learn it, but you know what I mean.
Got it. So imagine sudden cardiac death as a mystery where understanding the clues, like arrhythmias or risk factors, can help save lives. By piecing together these clues, you can become a detective in preventing it, making it a bit like solving a life-saving puzzle.
Okay, but I want to love the puzzle itself. I completely agree with you when it comes to attaching these morals into medicine, and this is what's kind of pushing me through the degree. But what about loving the puzzle for itself intrinsically, like Alficon says?
Try to appreciate the complexity and the challenge of understanding the human body. Each concept is like a piece of a grand puzzle, and mastering it can be quite satisfying. Also, finding the relevance to your future role as a doctor can create a deeper connection and motivation.
That's an amazing statement. Can you tell it one more time? In fact, you know what? I'll actively try to recall it. You're saying I should try to understand the clinical relevance, and also the other thing that you said is I should be trying to think of it as something that's part of a bigger puzzle.
Exactly. By understanding the clinical relevance, you'll see how each piece fits into the bigger picture. It can make learning more meaningful and enjoyable.
And how do we make sure that we're not going to like what's the word? How do we make sure that we um sorry guys, I've lost my trail of thought. You see what happens when we do experiment? It's okay. Yeah, I don't know what I was gonna say, to be honest with you. Let's get back to the topic, sudden cardiac death. And tell us more. Imagine we have, well, we do, but imagine we have 3 hours to talk about it. What would be the next step after the definition?
No worries. After defining sudden cardiac death, the next step could be exploring the risk factors and causes. Understanding these can help in identifying those at risk and implementing preventive measures.
And what's the risk factors?
Risk factors include underlying heart conditions like coronary artery disease, previous heart attacks, genetic predispositions, and lifestyle factors like smoking, obesity, and lack of physical activity.
Okay, can you tell them one more time?
Sure. Key risk factors include underlying heart conditions like coronary artery disease, previous heart attacks, genetic predispositions, and lifestyle factors, such as smoking, obesity, and physical inactivity.
Okay. What else should we know?
We should also know the symptoms and warning signs, like chest pain, shortness of breath, and fainting. Early recognition can lead to timely intervention and potentially save lives.
One more time, please.
Sure. Key symptoms and warning signs include chest pain, shortness of breath, and fainting. Recognizing these early can lead to timely intervention and potentially save lives.
And why do these things happen?
They happen because of electrical disturbances in the heart, such as arrhythmias, or structural problems like blocked arteries, which disrupt normal heart function.
Can you go more? Because you said fainting, you said chest pain, and you said one more thing. Can you go for each one? Can you give me the reasons for each one?
Certainly. Chest pain often occurs due to reduced blood flow to the heart, possibly from a blocked artery. Shortness of breath can result from the heart not pumping efficiently. Fainting might happen due to a sudden drop in blood pressure or irregular heartbeats disrupting blood flow to the brain.
But I don't understand how these things are connected with what happens.
These
Guys,
symptoms are
sorry for interrupting you. Guys, this is a 10-minute mark, which I've said to people to skip to. This is going well for me, and maybe this is interesting for you too, and it feels natural. So I'm gonna do it until the 20-minute mark instead. And sorry, guys, skip to that if you don't like it. And yeah, in the 20-minute mark, if this is going well, I might even keep it for a bit longer. But having said that, sorry, interrupted you. Could you say again what you were going to say?
Sure, these symptoms are connected to sudden cardiac events because they indicate the heart isn't functioning properly. Chest pain can signal a blocked artery, shortness of breath suggests inefficient pumping, and fainting might result from irregular heartbeats or blood flow issues to the brain.
Go deeper into this, because I can't correlate them yet.
Sure, chest pain, often due to reduced blood flow from blocked arteries, can indicate the heart muscle is not getting enough oxygen. Shortness of breath can happen if the heart can't pump effectively, causing fluid buildup in the lungs. Fainting may occur if the heart's rhythm is disrupted, temporarily reducing blood flow to the brain.
Interesting. Okay, let's get one by one then. I think this is going to be better if we get one by one.
Absolutely. Let's start with chest pain. It's often caused by reduced blood flow due to blockages in the coronary arteries, leading to insufficient oxygen for the heart muscle.
One more time.
Chest pain is usually due to reduced blood flow from blocked coronary arteries, which means the heart muscle isn't getting enough oxygen.
And why does this cause pain?
The heart muscle becomes starved for oxygen, which triggers pain receptors, signaling something's wrong. This is what we feel as chest pain or angina.
What receptors?
Pain receptors, also known as nociceptors, are sensory neurons that respond to potentially damaging stimuli by sending pain signals to the brain.
Nociceptors?
Exactly. Nociceptors are the sensory receptors that detect signals from damaged tissue and send pain signals to the brain.
Why are they called nociceptors?
They're called nociceptors because they detect noxious or harmful stimuli. The prefix noci refers to harm or injury.
Interesting. Interesting. Can you go deeper into why they're called nociceptors?
Certainly. The term nociceptor comes from the Latin word nocere, meaning to harm or to hurt. These receptors specifically detect harmful stimuli and signal potential damage, triggering the sensation of pain.
Mm-hmm. Okay, we've covered chest pain. Let's go to the other second thing you said.
Sure, the second symptom was shortness of breath. This often occurs when the heart can't pump effectively, causing fluid to build up in the lungs, making it difficult to breathe.
One more time.
Shortness of breath happens when the heart can't pump effectively, leading to fluid buildup in the lungs, which makes breathing difficult.
And why does it occur? I don't understand.
It occurs because when the heart isn't pumping properly, blood can back up into the veins that carry blood from the lungs to the heart. This increases pressure in the blood vessels of the lungs, causing fluid to leak into the lung tissues, leading to shortness of breath.
I know you're talking to me in English, but it feels like I don't understand. It feels like it's another language. Please, maybe break it step by step for my stupid brain.
No worries. Here's a simpler breakdown. When the heart can't pump well, blood backs up into the lungs. This extra pressure pushes fluid into the lung tissue, making it hard to breathe.
One more time.
Sure. When the heart can't pump efficiently, blood backs up into the lungs, causing fluid buildup, which makes breathing difficult.
Got it. Now I get it. Okay, perfect. And let's go to the third one.
Great. The third symptom is fainting. This usually happens when there's a sudden drop in blood flow to the brain, often due to irregular heartbeats disrupting circulation.
One more time, sir.
Fainting happens when there's a sudden drop in blood flow to the brain, often due to irregular heart rhythms that disrupt circulation.
So we don't have blood flow. Yes, that makes sense too. Okay, so we've talked about so our topic today is cardiac syncope, right?
Yes, we're discussing sudden cardiac death, and cardiac syncope is one aspect of it, as fainting can be a warning sign.
Sorry. Guys, I'm the worst host ever, aren't I? Yes. So, no, sudden cardiac death. This is what happens, guys, when I don't follow the scripts. But it's a good experiment. I want to know. And you know what, guys? I want to know because the script is basically. I'm not plagiarizing anything, but it's from universities, and I'm just kind of seeing how much could we actually cover if we talked with ChatGPT for 2 hours, and then I go to the script and see what's left. And maybe we've learned it more naturally this way, and we didn't force as much. And okay. So we're talking about sudden cardiac death, and we've talked about 3 symptoms. What else should we know?
We've covered symptoms. Next, it's important to understand the causes, like arrhythmias and structural heart issues. Then we can talk about prevention and management strategies.
Okay, let's go for it.
Arrhythmias, like ventricular fibrillation, are a common cause. They disrupt the heart's electrical activity, preventing it from pumping effectively. Structural issues like cardiomyopathy can also weaken the heart. Prevention focuses on managing risk factors like high blood pressure, maintaining a healthy lifestyle, and regular checkups.
Interesting. So you mentioned arrhythmia and ventricular fibrillation. Could you expand on this, please?
Absolutely. Arrhythmias are irregular heartbeats. Ventricular fibrillation is a severe type where the heart's ventricles quiver instead of pumping normally. This disrupts blood flow, leading to sudden cardiac arrest if not treated immediately.
It's one of these, but I can't concentrate. I'm sorry, guys. Okay, one more time, perhaps if you break it step by step.
Sure, no problem. Arrhythmias are irregular heartbeats. Ventricular fibrillation specifically is when the heart's ventricles quiver instead of pumping properly. This prevents normal blood flow and can cause sudden cardiac arrest if not treated quickly.
Interesting. Okay, so arrhythmias is another thing that might cause sudden cardiac death. Okay, and okay, can you how so we don't so when the heart isn't so okay, you said ventricular fibrillation. So basically the electrical conductance on the heart of the heart is messed up in ventricular fibrillation, you say, and if it's too messed up, the heart will die.
Exactly. In ventricular fibrillation, the heart's electrical signals become chaotic, causing the ventricles to quiver instead of pumping blood. If not corrected quickly, it can lead to sudden cardiac death.
You know, this is really interesting. I was doing some nice research on chaos theory in medicine, and it was talking about how in ventricular and atrial fibrillation, if you find the Hopf bifurcation, which is the point where the system starts becoming like starts this instability, and apparently this is a physical point in the heart, and then if you can kind of eliminate it by, I don't remember if it was by a catheter or some other method, or to go there to eliminate it, you can kind of perhaps stop the chaos a bit. It's really interesting.
That's fascinating. Finding and addressing the Hopf bifurcation point could indeed help stabilize the heart's rhythm and prevent fibrillation. It's a promising area for future medical advancements and treatments.
Yeah, that's really cool. Sorry, guys, my dogs are here, but yeah, we can continue the conversation. So so yeah, besides chaos theory though, let's go back. What's the next step? We've talked about arrhythmias. Now, what's the next step?
Next, we can talk about structural heart issues like cardiomyopathy, which weakens the heart muscle and can lead to sudden cardiac death. Understanding these structural problems is crucial for prevention and management.
Cardiomyopathy. Yeah, let's do it.
Cardiomyopathy refers to diseases of the heart muscle, where it becomes enlarged, thick, or rigid. This can weaken the heart, making it harder to pump blood effectively, and can lead to heart failure or arrhythmias, increasing the risk of sudden cardiac death.
Okay, and so let's go a bit more on a deep dive with cardiomyopathy. What's the so this is just a general way to talk about diseases of the heart, or is it a specific one? Like, what about heart failure and myocardial infarction? Are they a type or something different?
Cardiomyopathy specifically refers to diseases that affect the heart muscle itself, making it harder for the heart to pump blood. Heart failure is a condition where the heart can't pump blood effectively, often as a result of cardiomyopathy or other issues. Myocardial infarction, or heart attack, is caused by blocked blood flow to the heart, damaging the heart muscle. They're related but distinct conditions.
Okay, and how can I distinguish between them as a doctor?
Distinguishing them involves looking at symptoms, patient history, and diagnostic tests. For example, an ECG can help identify arrhythmias or heart attack. Imaging tests like echocardiograms can assess heart structure and function, helping to diagnose cardiomyopathy. Blood tests can also reveal markers of heart damage.
Okay, let's talk more about cardiomyopathy because I'm a bit confused. So, can you? And sorry, guys, but could you exactly explain to me? 20-minute mark. Yeah, we're going for this for another hour, I think. So yeah. Could you explain again cardiomyopathy?
Certainly, cardiomyopathy refers to diseases of the heart muscle that affect its size, shape, or thickness. It can make the heart weaker, reducing its ability to pump blood effectively, and can lead to arrhythmias or heart failure. There are different types, like dilated, hypertrophic, and restrictive cardiomyopathy, each affecting the heart in different ways.
And let's go to these different types. Maybe it's going to help me understand what it is in general.
Sure. Dilated cardiomyopathy is when the heart's chambers enlarge and weaken. Hypertrophic cardiomyopathy involves thickened heart walls, making it harder to pump blood. Restrictive cardiomyopathy is when the heart muscle becomes rigid, limiting its ability to expand and fill with blood.
One more time, please.
Of course, dilated cardiomyopathy is when the heart chambers enlarge and weaken. Hypertrophic cardiomyopathy involves thickened heart walls, and restrictive cardiomyopathy is when the heart muscle becomes rigid, limiting its ability to fill with blood.
Okay. Okay, we've talked about cardiomyopathy, which, to be honest, I'm still finding it a bit difficult to understand, but we can come back to it. Just remind me. Let's talk about the next step.
Sure. Next, we can focus on prevention and management strategies, like lifestyle changes, medications, and regular medical checkups, which can help reduce the risk of sudden cardiac death.
Okay, let's do it.
Prevention includes maintaining a healthy lifestyle, regular exercise, a balanced diet, and avoiding smoking. Medications can manage risk factors like high blood pressure. Regular checkups help catch issues early. For those at high risk, devices like pacemakers or defibrillators can be life-saving.
Okay, wow. Okay, we've talked about a lot of different things. Okay, we've got a lot more time to talk about our topic, which is sudden cardiac death. So, what else do you think is important?
Another important aspect is recognizing early warning signs and symptoms, like chest pain and fainting, and knowing how to respond quickly. Educating people on CPR and the use of AEDs can be life-saving in emergencies.
Okay, CPR. Let's talk about CPR then.
CPR, or cardiopulmonary resuscitation, is a life-saving technique used when someone's heart stops beating. It involves chest compressions and rescue breaths to maintain circulation and oxygenation until medical help arrives.
Interesting. Okay, so I'm a bit unsure of what to ask you since it's a bit weird for me, guys. I don't have my script. So, how can we continue this conversation learning more about sudden cardiac death?
We can explore real-life scenarios and case studies to understand how sudden cardiac death occurs and how it's managed.
Let's do it.
Discussing it.
Let's do it.
All right, let's consider a scenario where someone experiences sudden cardiac arrest in a public place. Quick action, like calling emergency services and starting CPR, can significantly improve their chances of survival.
Interesting. Okay. Perfect. Okay. And can you tell us more about this?
Sure. For example, there are cases where people survive sudden cardiac arrest thanks to quick CPR and defibrillation. Advances like wearable defibrillators and improved emergency response systems are also making a big impact.
Interesting. What are these?
Wearable defibrillators are devices worn like a vest that can detect life-threatening arrhythmias and deliver shocks to restore normal rhythm. They provide continuous monitoring and protection for at-risk patients outside the hospital.
Okay. So, let's talk a bit about causes again.
Certainly. Another cause is coronary artery disease, where plaque builds up in the arteries, reducing blood flow to the heart. This can trigger a heart attack, leading to sudden cardiac death.
And why does coronary disease happen? Coronary artery disease.
Coronary artery disease occurs when plaque, made up of fat, cholesterol, and other substances, builds up in the walls of the coronary arteries. This narrows the arteries, limiting blood flow to the heart muscle, which can lead to chest pain or heart attacks.
Interesting. Okay. And so let's talk more about other causes then.
Another cause is structural abnormalities, like congenital heart defects, which can affect the heart's function and rhythm. Additionally, severe electrolyte imbalances, like potassium or magnesium, can also cause dangerous arrhythmias leading to sudden cardiac death.
Can you repeat that a bit? Tell us more about it.
Sure, structural abnormalities like congenital heart defects can impact heart function and rhythm. Additionally, severe imbalances in electrolytes, such as potassium or magnesium, can lead to dangerous arrhythmias that may cause sudden cardiac death.
Interesting. Okay, so imagine that, which is the truth anyway. Imagine in the next 2 hours, we're going to be still talking about sudden cardiac death. And we want to cover everything about sudden cardiac death as someone that's just finished medicine would have covered at school. Or at least someone that's finished year one, let's say. What else should we know? I want you to structure this podcast in a way where, well, you're the master here. So, in a way where we can learn all these things and start from the general to the specific. Yeah.
Absolutely. Let's start with an overview of what sudden cardiac death is, followed by its symptoms and causes. Then we can dive into specific risk factors, diagnostic methods, and prevention strategies. Finally, we'll cover treatment options and real-life case studies. Does that sound good?
Perfect.
Great. We'll begin by defining sudden cardiac death and its significance. Then, we'll discuss the common symptoms like chest pain and fainting. After that, we'll explore the various causes, such as arrhythmias and structural issues. Then we'll move on to risk factors and diagnostic methods. Finally, we'll wrap up with prevention, treatment options, and some real-life examples. Let's get started.
Let's do it.
Awesome. So, sudden cardiac death is an unexpected death caused by a loss of heart function, usually from an electrical malfunction in the heart. It can happen suddenly, often without warning.
Okay.
Now, let's talk about some common symptoms like chest pain, shortness of breath, and fainting, which can often be early warning signs.
Well, we've already covered that.
That's right. Moving on, let's discuss the causes, such as arrhythmias, which are irregular heartbeats, and structural issues like cardiomyopathy.
Well, we've already talked about that too.
You're right. We've covered arrhythmias and cardiomyopathy. Let's move on to discussing risk factors, such as genetics, lifestyle, and pre-existing conditions.
We've already talked about that too. I think we've talked about all of these things, but I don't think we've done it in enough depth. So we should take every single of these fields and go in more depth.
Got it. Let's start with arrhythmias. We can dive deeper into how different types, like ventricular fibrillation, specifically affect the heart's electrical system and lead to sudden cardiac death.
Let's do it.
Ventricular fibrillation is a type of arrhythmia where the heart's electrical activity becomes chaotic, causing the ventricles to quiver instead of pumping blood. This drastically reduces blood flow to the brain and other organs, often leading to sudden cardiac death if not treated immediately.
Well, we've already kind of talked about this though. Yeah, so I like your general structure of what we should be talking about for today, but let's kind of let's spend perhaps 15-20 minutes on each topic. So you mentioned treatment options, you mentioned symptoms, you mentioned causes, etc., etc. Let's divide it into 5 categories and let's spend 15 minutes on each. And let's start from the first category.
That sounds like a solid plan. We'll start with the first category, symptoms. We'll dive into the specifics of warning signs like chest pain, fainting, and shortness of breath, and what they indicate. Let's explore these in detail.
Yeah, before we do that, I want to add one more initial category, which is going to be history and significance and definitions. Let's do 20 minutes on that.
Sounds good. We'll begin with the history, significance, and definitions of sudden cardiac death to set a solid foundation. Let's dive into the origins and why it's important to understand this condition.
Let's do it.
All right. So, sudden cardiac death has been recognized throughout medical history as a significant cause of mortality. It's crucial because it often occurs unexpectedly and can affect anyone, highlighting the importance of awareness and prevention.
Okay, tell us more.
Historically, sudden cardiac death was often attributed to unexplained causes, but
Yeah.
I'm sorry, but historically, it was often misunderstood, with cases recorded as far back as ancient Greece. Over time, medical advancements like ECGs, defibrillators, and genetic research have helped us better understand and prevent it. Its significance lies in its unpredictability and the fact that early intervention, like CPR and AED use, can mean the difference between life and death.
Tell us more.
Sure. In the past, sudden cardiac death was often attributed to mysterious causes or even supernatural explanations. Ancient physicians like Hippocrates noted cases of sudden collapse, but without knowledge of the heart's electrical system, the true cause remained unknown. Fast forward to the 20th century, and we see major breakthroughs. The development of the electrocardiogram, ECG, allowed doctors to visualize and diagnose arrhythmias, which are often the culprits behind sudden cardiac death. Then came the invention of the defibrillator, which revolutionized emergency response by allowing rapid correction of fatal heart rhythms. Today, we understand that sudden cardiac death isn't just a random event. It has risk factors, including coronary artery disease, genetic mutations, and lifestyle factors like smoking and poor diet. This knowledge has led to preventative measures, including medications, implantable cardioverter defibrillators, ICDs, and widespread CPR training. So, while sudden cardiac death remains a critical public health issue, our ability to predict, prevent, and treat it has never been better. Absolutely. One of the biggest game changers in understanding sudden cardiac death was the discovery of its link to arrhythmias. In the mid 20th century, researchers identified ventricular fibrillation as a primary cause, where the heart's electrical signals become chaotic, stopping effective blood flow. From there, treatment methods evolved rapidly. The invention of the external defibrillator in the 1940s allowed doctors to restore normal heart rhythm with an electric shock. Later, the development of implantable cardioverter defibrillators, ICDs, in the 1980s provided long-term protection for high-risk patients by automatically correcting dangerous arrhythmias. Significantly, studies also revealed the role of coronary artery disease in sudden cardiac death. Blocked arteries can restrict blood flow to the heart muscle, increasing the risk of lethal arrhythmias. This led to the promotion of heart-healthy lifestyles, cholesterol-lowering medications, and procedures like angioplasty to reduce risk. Despite these advancements, sudden cardiac death remains a leading cause of mortality. That's why education, early screening, and quick emergency responses, like widespread CPR and AED accessibility, continue to be crucial in saving lives.
Okay. So, guys, and just so you know, this bit, these 35 minutes, are gonna appear at the end of the podcast, as I've just spontaneously decided. So this was a test on how things would run if I didn't have a script, basically, from a university with ChatGPT. And from my understanding is, ChatGPT is amazing at answering, but I don't think it might have the capability yet of kind of providing us a book of knowledge, if that makes sense. Like, I think it could answer us all the questions, but perhaps it couldn't necessarily, or maybe I'm not that interested or good to ask it about the right things to kind of unravel everything that a university kind of a university lecture, let's say, would have covered, because my questions aren't really good. Yeah, I mean, fair enough. The good thing is we do everything with the script anyway, which is a general script. And yeah, I'm gonna be back to the script in a few hours, actually. Well, not in a few hours when you're watching this, but in a few hours when I'm doing this. And yeah, I'll do the episode how we usually do it, and I'm gonna mention in the start of the episode and at the end that this is gonna be a bit in the end, like as a special bonus of a, you may say, failed experiment. I'll say an experiment in progress, because I think there's ways around this. But yeah, I want you guys to have the proper episode that's actually gonna help you really well with medicine. And yeah, I mean, love you guys and girls, and I'll see you next time.